All right, and again, this is not affiliated with school in any way, but if you do not follow IEA on Instagram, you should. We're offering tutoring now, and we do the facts of the day too. So you should do that. Now, let's talk about heart failure. So the first thing I want to talk about is, so you don't go directly into heart failure, right? So you first get systolic or diastolic dysfunction, right? So this dysfunction will eventually lead to heart failure. But we want to talk about this process, right? Because by the time the patients come in, a 65-year-old male, they come in and their hearts, they've been through systolic, diastolic dysfunction. And you know, what was this process over the past 20 years that exactly happened? As we know, the body has this amazing way of compensating for all of these pathological deficits we develop, right? So that's why by the time your patient comes in and they're symptomatic, you know, their heart functions down to, you know, their ejection fractions down to 20%, or their renal perfusion or their GFR is down to 20%. That's just because the body has great ways of compensating. But it means by the time you get symptomatic, you're usually in the later stage of the disease. So we want to define systolic dysfunction and diastolic dysfunction before we become symptomatic. By the time you become symptomatic, then technically you're in heart failure. So what's the process, right? So typically what happens is we're going to go into systolic failure first, okay? The systolic dysfunction first, not failure. So what does that mean? What does systole mean? That is ejection, right? This is your pump, right? That is when the ventricle squeezes and all the blood goes out of the ventricle, right? So this is by definition pump failure. Can you properly get blood into the ventricle? Yeah, you're good at that point. But the systolic dysfunction is a problem with the pump, okay? So what typically happens that's gonna cause this? Well, at least in the US, MIs, right? If you have some sort of myocardial infarction, if you have a heart attack, some of that tissue is going to die, right? And by definition, if the tissue that is acting as the pump dies, you're going to go into systolic dysfunction, eventually maybe even systolic heart failure. So when you hear systolic dysfunction, I want you to think of pump failure. Now, what are some other causes that can lead to this systolic dysfunction? Well, what if we had long-standing hypertension? Or even, let's use aortic stenosis, okay? We'll just make a caveat real quick. I just want to point this out. Here's a trick I always use. If they ever give you a patient that's like 70 plus years old, I always think aortic stenosis first, okay? And that's just because age-related calcification of that aortic valve is like super prominent. So if you ever see a 70-plus-year-old patient in a question, think aortic stenosis. Okay, now let's get back to it, right? So now, what are we talking about with hypertension and aortic stenosis? We're talking at a very much elevated afterload, right? So hypertension, the pump has to squeeze against all of that systemic vasoconstriction, right? You're blowing through a very narrow straw, right? Aortic stenosis is a stenotic valve. Again, you're trying to pump through a very narrow opening. So again, the pump is going to start to fail, right? If either you have some sort of MI that causes the myocardial damage, so the pump's not strong enough, or you're just having to work so hard that against this high afterload that eventually it's going to have dysfunction and lead to failure. Now, so what happens at this point? At this point, we're going to have a backlog of blood into the ventricle, okay? So that means we're going to have an increased end diastolic volume, okay? So what am I saying? I'm saying that the pump has begun to fail. You're squeezing so much that, and it's failing, so that blood that is supposed to go out of the ventricle is staying in the ventricle, okay? So sometimes they say this pump failure is like is like the walls are floppy, right? So if you have a myocardial infarction and some of the wall is dead, it gets floppy. But the point is that you can't properly squeeze all of the blood out of the ventricle. So you're going to get increased blood left over. After systole, after that pump ejection, right? So by definition, this is going to just congest that ventricle and you're going to get an increase in diastolic volume. Okay, so now we have our precursor to what's going on. Now, there's nothing in medicine is black and white. There are grays to everything. Some patients, particularly renal patients that have volume overload, they can go into diastolic dysfunction first. But this is classic, especially in the United States. You're going to go into systolic dysfunction first, typically MI or some sort of longstanding hypertension. Okay, so now what we see is, and this is pretty classic for everyone. At this point, this systolic dysfunction, you're kind of living with it. You're like 5-10 years into your hypertension, like you're fine. But at some point, this end-diastolic volume is going to be a problem. Okay, so what you're going to actually end up doing is you're going to try to hypertrophy the ventricle. Why are you doing that? You're trying to make the pump strong again, right? That's your goal. Now, the body's not thinking the long-term consequences of hypertrophying the ventricle. It's saying this pump isn't pumping a lot of blood. We're going to try to hypertrophy the ventricle. We need to make the ventricle thicker so the pump works better. Okay, right. So you're starting to do this. But then what happens, right? Then this ventricle hypertrophied, strong and muscular, it ends up getting stiff, okay? Just because it's a lot of muscle there. So then at this point, you're in trouble because now you're going to go into diastolic dysfunction. And what do we use synonymously for diastole, like where systole was pump failure? This is a filling failure. Okay, so I hope this makes sense to you guys. We went through this process, right? So now we hypertrophied the ventricle becomes stiff. Now, if you have a stiff ventricle, it's not compliant anymore, right? It's not gonna, when you wanna put blood in it, it's not gonna get bigger, right? So you are going to now be in diastolic dysfunction, a filling problem, okay? So maybe you're able to, maybe you were able to compensate a little bit with that hypertrophy by making the pump stronger, but now because you hypertrophied it, you made it stiff, it's not compliant, meaning it's not going to stretch. So now you have a problem filling the ventricle. Okay, so this is the process. Now, in real life, it's not like this linear thing where you go into systolic dysfunction, then go into diastolic dysfunction, then systolic failure, diastolic failure. It kind of happens synonymously, but we know what our primary cause was, right? Our primary cause was this, well, it had MI or hypertension or whatever led to the systolic or pump problem. But you could see the process. By the time this 65-year-old patient comes in with problems breathing and chest pain on exertion, you're already at this point where you're having trouble filling, okay? So this is the whole process of how this works. So make sure you keep in mind these ideas of systole is a pump, systolic is a pump failure, whereas diastolic is going to be a filling failure. Now, there's just one more thing I wanted to add, and that is this ejection fraction thing. Because on the surface, if you said something had a preserved ejection fraction, you say, okay, that sounds good, right? Okay, maybe not. So when we talk about systolic, let's say failure, right? So we have a problem with our pump. Can we get adequate blood out of the ventricle? Well, no, because the pump's not working right. So in systolic failure, you're going to get a decreased ejection fraction, right? Ejection fraction is the fraction of blood that gets out of the ventricle compared to what was in there before. You're in diastolic volume. So this is the same thing as saying heart failure with reduced ejection fraction. Now, why is it reduced? Because the amount of blood in the pump is not working. The pump is not working. It's systolic failure. So when the pump squeezes, it doesn't squeeze as well. So that amount of blood you're gonna have a decreased ejection fraction, decreased amount of blood there. It is coming out that should have, okay? So the pump is not squeezing hard enough because it's floppy, there's dead tissue, then you're going to get a decreased ejection fraction. So when we talk about the pharmacology behind it, there are certain drugs such as digoxin, which they don't really use anymore, but it's a very classic example. You can make the pump work a little bit better, okay? They love to test on it. So if it makes the pump, it's an inotrope, so if it makes the pump work stronger, you can help to rectify this ejection fraction problem. Now let's look at diastolic. All right, so now we have a filling problem. Now, if I told you you had a heart failure, but a preserved ejection fraction, you'd be like, well, okay, I mean, then I'm getting the right amount of blood out, right? No, that's not what's happening. The problem is that the heart is filling with less blood. Okay, so let's just I'll use arbitrary numbers here. Let's say you originally had 10 liters in your, I know you don't, but if you had 10 liters in your heart and you were able to eject 5 liters of that, all right? That's an ejection fraction of 55%, okay? Which is about, the liters aren't correct, but your ejection fraction is around 55%. That's what it should be, okay? Now, if we had a diastolic failure, let's say the heart was only able to fill with 8 liters. Right? And of that 8 liters, you got 4 liters out. You were able to eject 4 liters, okay? Well, sorry, this would have been 50%, right? 50%, right, 10 of 5, you get it. So let's go back. If you had originally, before you had heart failure, you had 10 liters in your heart and you ejected 5, you'd have an ejection fraction of 50%, okay? Now you're in diastolic failure. Your heart can only fill with 8 liters instead of the original 10 liters. And you're able to eject 4 liters of that. Well, your ejection fraction is still 50%, right? So that doesn't mean that's not good. Like there's still less overall blood. You'd have to look at the actual cardiac output to figure it out. So just understand that preserved ejection fraction doesn't necessarily mean like you're getting out the amount of blood you should. It just means from the amount of blood that was in the ventricle coming out, you're still getting, the same percentages out of it. Okay, so just keep that in mind. If you have a pump failure here, you're going to have a reduced ejection fraction because the pump's not working. If you have a diastolic failure here, you'll get a preserved ejection fraction, but that's only because you had a problem filling. You weren't able to fill it up properly. Okay, so those are some of the tricky things. If you get those straight, some of those higher 3rd or 4th order questions, you'll be okay with. All right, where am I at here? Okay. Do y'all have any questions? I'm gonna let Lindsey take over. She's got the slides for the pathology stuff. Do y'all have any questions about that? Because that's kind of the basis of like understanding and not just regurgitating answers. Like, okay. All right, Lindsey, it's all yours.
Cool. Hey guys, so we're gonna go over, the path. So this is tips on approaching all types of questions on these exams. FTCM was kind of like FTM in that it was different in how you studied. I felt that from CRS on, you could kind of think about the questions in the same way and you would be successful. So for both path and micro, make sure that you are identifying the clinical presentation because that's what's going to be in the vignette. So it'll describe the patient and then ask you something about the pathology. For the pathology, they love risk factors and complications. So for example, atherosclerosis is a big risk factor for a lot of cardiac diseases. And then if there's a complication down the line, they love risk factors and complications. And sometimes those are very small tidbits on the slide and it's not touched on greatly. It's like a small text. But make sure that if you're seeing that you are highlighting it and noting it because it's very high yield. if there's a gene that's associated with something that's also high yield, at risk for something down the line. And then micro, again, they're going to describe it, and they love asking about the characteristics of the causative agent, or what is the causative agent. So we'll go over that, but sometimes it's as small of a detail as gram positive diplococci, or single stranded positive sense RNA, like down to that kind of detail. So just be aware of that. And then histo slides are your friend in year 2. The reason being, in year 1, it was really tedious because histo was all about identification and what are you looking at. For year 2, when you're talking about pathology, histo is actually your friend, and it's actually going to be one of those buzz things to clue you in on what you're looking at. So when you see histo, don't fret, actually rejoice, because that can be an easy trigger, an easy buzzword for a pathology. Then pharm, mechanism of action, ADRs. If something has a very specific one, then they're probably going to test it. But at this point, work backwards. What I did is, because they have those summary slides where they say this is how you treat hypertension, this is how you treat heart failure. Work from those slides and go backwards and say, okay, this is first line, this is second line, this is what you give, and then look at mechanism of action and ADRs. Because at this point, hopefully you've all gone through everything. So just make sure that you know the formula of how to treat somebody with a certain pathology. Okay, so we're going to cover high yield points for each. I condensed this greatly. I went through the slides and I picked out the things that I think you need to focus on at this point in your studying. We'll talk about the pathology, the pathogenesis and everything, but I made a point to pull out the big high yield buzzwords for all of the pathologies that we're going through, and then the histo as well. So CVS, atherosclerosis. So don't get this confused with arteriosclerosis. We're going to talk about arteriosclerosis in a sec, but atherosclerosis, this is associated with hyperlipidemia. So this is the where you get the plaque. So risk factors, they love modifiable versus non-modifiable. So things you can and can't control. Smoking is a big one they like to focus in on. Some other ones are, if it's associated with atherosclerosis, you're going to have increased lipids, that's hyperlipidemia, and then hypertension and diabetes, of course, and then non-modifiable, age, male, family history, genetics. Yes, unfortunately, there are ethnicities and genders that are going to be predisposed to some pathologies. So this leads to a lot of bad stuff. Atherosclerosis is at the heart of a lot of coronary pathology. So just understand that. So it can affect essentially any elastic artery. So coronary, cerebral, peripheral, vascular, and leads to a lot of bad stuff. So essentially it gets weak. If you have something else that's depositing on your vessel, the vessel is going to be weak and things are going to happen. So it's going to be susceptible to rupture, and we're going to talk about aneurysms in a bit. It can also lead to an obstruction flow. So MI and angina. MI would be like a complete obstruction where you're getting ischemia and tissue death, versus angina, which is just ischemia and then it's reversible. But pathogenesis, you can get some endothelial injury, hint, smoking, that's direct endothelial injury. And then once you get that endothelial injury, your inflammatory process, you have increased vascular permeability, which lets a lot of stuff in, including leukocytes. You have accumulation of oxidized, that's supposed to say LDL, I apologize for that, in the vessel. Monocytes arrive, transform to macrophages, and you get foam cells, platelets that adhere and activate, releasing factors. Something big that they like to touch on, small muscle cell recruitment and proliferation. And then that's supposed to say ECM. Apparently my fingers are dyslexic. Sorry, guys. But smooth muscle cell recruitment, and then ECM production, T cell recruitment. And then abdominal aorta is the biggest one. So yes, do know the occurrence. So atherosclerosis is most common in the abdominal aorta. Second would be the iliac artery, followed by coronary popliteal, ICA, internal carotid, and then circle of Willis. So this is important to note. You have a vulnerable and a stable plaque. Notice that the vulnerable plaque has a very thin cap and a thick core. That cap can be very easily ruptured, and you get a lot of bad stuff if that ruptures. You can get a thrombosis, which happens after the plaque, and that thrombosis can get lodged essentially anywhere. But thrombosis is very increased risk of heart attack, so complete occlusion there. And then stable plaque is the thick cap and thin core. So do know what makes it vulnerable versus what makes a plaque stable. Clinical consequences, plaque rupture, that gives you a, you can get hematoma there, blood leaking, erosion and thrombosis. Remember, thrombosis can result in occlusion, and then fibrocalcific plaque, which is stenosis. And then if you have something that is stenosed, then you are not going to have good compliance, and compliance is important to adjust to different changes. So that is not good. So some clinical consequences, again, this is really important. If something is has a consequence down the road, you need to take note of this. This is more of an umbrella of consequences because atherosclerosis is such a widespread thing, but just understand coronary heart disease. We're going to talk about that. A vascular disease, so stroke. So thrombosis can go and they can cause ischemic strokes because it can lodge in any of the arteries in the brain. That's how you get stroke, ischemic stroke. And then abdominal aortic aneurysm. Those are quickly fatal. And then peripheral vascular disease. Okay, so hypertension, you have benign versus malignant. Benign, you know the histologic characterizations. This doesn't just happen in one place, this is everywhere. So when we go over renal path, we're going to talk about the effects of this there too, because it's going to be the same thing. So benign, you get hyalinization of the vessel wall because this is chronic stress over time. So the vessel essentially has the ability to adjust to what's going on. So you have hemodynamic stress, continual hemodynamic stress, you get deposition of the hyaline that leads to the luminal narrowing and then impaired blood supply, which can give you ischemia. And then malignant hypertension is a sudden increase in blood pressure. And what makes it malignant is end organ damage. So in response to the sudden increase, you're going to get duplication of the basement membrane, and then very, very, very important, smooth muscle cell hyperplasia. Please highlight that. That is a very big factor of this pathogenesis and what makes it bad. So like I said, histo is your friend here. You can clearly see the difference between the hyalinized vessel versus the onion skin appearance, because you get that you get essentially the duplication of the basement membrane. So it just kind of goes on top of each other. So you can see the layers, you can see the concentric layers. And then that's what's going to clue you in on, okay, this is malignant hypertension. And then this is associated with fibrinoid necrosis. So necrotizing arteriolitis, you'll remember fibrinoid necrosis from FTCM. Aneurysms, this is just a dilatation in the wall. Remember, something that can lead to this is going to be the atherosclerosis. Why? Because it makes the walls very weak. So you can get that dilation of the wall. True, all layers involved. False, it's just a wall defect and it can lead to an extravascular hematoma. At the top, I put the different kinds. So true saccular, fusiform, and then a false aneurysm, which is just the hematoma in the extravascular tissue. Some etiologies, of course, atherosclerosis, we already talked about that, syphilitic and mycotic, we're going to reference those later. And then vasculitis, so polyarteritis, nodosus, and Kawasaki's, then Marfan's, there's supposed to be a comma there, Marfan's, comma, Berry. Marfan syndrome, of course, it's connective tissue disease, and you will get weakening. And then Berry aneurysms are associated with a bunch of different things, but Berry aneurysms are very bad because they can lead to a subarachnoid hemorrhage if they are ruptured. The big thing here, remember this cystic medial degeneration. So you have alteration of the structural integrity, again, from the smooth muscle cell and extracellular matrix alterations. That's very important. The most common cause of AAA, which is abdominal aortic aneurysm, that's atherosclerosis, and that's different from the ascending aorta. But why? Because the plaque is going to increase diffusion distance, so you're going to get ischemia of the inner media. I have the picture down at the very bottom. So what is the basis of this? Large vessels need nutrition too. So you have the vasa vasorum, which are little arteries that are running in the wall of the vessel, and they're providing nutrition for that area. So if you have an atherosclerotic plaque, you are increasing that diffusion distance. So if you increase that distance, then you're not going to get enough nutrition to that inner media. Whereas most common cause of ascending aorta aneurysm is hypertension. Why? Because hypertension, you're going to have narrowing of the vasa vasorum, and then you have ischemia of the outer media, and then of course loss of smooth cells and aortic degeneration. So just understand that the vasa vasorum is very important in the pathogenesis of the aneurysms. Why, AAA is going to be the atherosclerosis and the diffusion barrier, and then the ascending aorta, it's going to be the narrowing of the vasa vasorum due to the hypertension and the stress. Okay, continued. So we said that atherosclerosis is going to give you the AAA. What is the biggest risk factor? Smoking, which makes sense because when we went back and we talked about the atherosclerosis, the biggest risk factor was smoking. Why is it smoking? Because smoking is going to give you endothelial injury. It's going to have an insult on there. And then you get this process that eventually leads to an atherosclerotic plaque. But you need to understand that people get that confused all the time, how the AAA, so abdominal aneurysm, is due to smoking. So smoking leads to atherosclerosis, leads to weakening, and you get the AAA versus the ascending, that's going to be hypertension. Can be asymptomatic, but you can also see it in a pulsating mass. If you have a ruptured abdominal aneurysm, not good. So a patient's going to present, I didn't put this on the slide, I don't know why, but a patient's going to present with chest pain that radiates to their back. That's the biggest pertinent positive symptom that you can have. You can have the pulsating abdominal mass, that's more if it's not ruptured, but it's the severe, it's described as a ripping chest pain that radiates to the back. That's how you know, that's what can clue you in on a AAA. You can also have a mycotic aneurysm, that is commonly due to salmonella, so just make that note there. And then syphilitic aneurysm, this is due to tertiary syphilis. I put the picture on here, the tree bark appearance. This is the hallmark of the syphilitic aneurysm, and it's due to obliterative endartitis of the vasa vasorum, which leads to the medial destruction and weakening. Again, we talked about how vasa vasorum is very important in the pathogenesis of aneurysm. So here, when we're talking about the syphilitic aneurysm, you're getting obliterative endartitis of the vasa vasorum. But it is that tree bark appearance. I put that picture there. You can look up a couple more pictures if you want to know what that looks like. But if you see something called tree bark appearance or something, you're talking about it, and it's obliterative endartitis. Again, Marfan's, fibrillin, and then Berry. Berry is associated with autosomal dominant polycystic kidney disease, and then the rupture causes subarachnoid hemorrhage. Aortic dissection. So this is blood separating in the laminar planes of the media. So it creates a blood-filled channel in the wall. Why is this bad? Because, well, it's not in the lumen, so it's not going to go to the systemic tissues. And so you're basically getting this big hematoma. Middle-aged men risk hypertension. Kids are more at risk if they have a syndromic disease, so Marfan's Ehlers-Danlos syndrome, so connective tissue. So if you get it young, it's probably because there is some kind of defect. If you get it older, it's because you have continued stress on the area that's weakening it over time, so hypertension. Most common cause of death is going to be rupture and bleeding into the pericardium, the pleural space, the peritoneal cavities. So your blood volume just immediately crashes and you go into hypovolemic, all kinds of shock, but hypovolemic shock. And then you can get retrograde dissection to the aortic root. So instead of going down, it's going to go back near the heart, which can disrupt the valve annulus at the heart. You can get cardiac tamponade, aortic insufficiency. If it can extend to the great arteries of the neck and into other arteries. So if you get if it extends into the coronary arteries, you're going to get an MI because the coronary arteries supply nutrients to the heart. And if you can't get that, you're going to get ischemia and then tissue damage. And then spinal arteries, if it goes there, you get transverse myelitis. Oh, and at the top right, that's just the clinical presentation. So if you're looking at the vignette, that's what you're going to see. Continued. The big thing histologically, you're going to see cystic medial degeneration, and then just smooth muscle cell dropout necrosis, elastic tissue fragmentation, and accumulation of the amorphous proteoglycan-rich ECM. Vasculitides, this took me a little bit to get down, but there are a few things in each that are going to clue you into this is it. So this is just inflammation of vessels, that simple as that. If you want an overarching definition, the umbrella term. So vasculitides, just inflammation. So you have different ones affecting the large vessels, the medium vessels, and then the small vessels, and they're going to have different presentations of each. So starting with the large vessel, you have giant cell arteritis. A really common one, or not common, but common that you hear about is going to be temporal arteritis. So you're going to come in with like this really bad headache, jaw claudication, ocular symptoms, like this really terrible headache, temporal pain. So you have to do a biopsy of the temporal artery to know what it is. The big thing here, it can lead to blindness. It can lead to permanent blindness if you don't catch it and treat it early. So preponderance is over 50, females more than males. Sorry, women. And then this is going to be T cell mediated. And then this is associated with polymyalgia rheumatica. Large vessel, again, Takayasu arteritis. So this is going to be a pulseless disease. So the patient is going to come in with weak or absent pulses in the limb. So that if you have a vignette that says that clues you in on, okay, this is Takayasu arteritis. You can also fever, night sweats, arthritis, myalgia, skin nodules, which all this makes sense because you're getting inflammation of the arteries. And so downstream, you're getting all of these symptoms. So aortic arch, great vessels, renal artery, vertebral, young girls, and then you have granulomatous thickening and narrowing of the aortic arch. So if you hear that description or you see this image, that's what you are talking about here. Then medium vessel, crap, I forgot what that stood for. Sorry, guys. So young adult patient's going to present with just general symptoms of fever, sweats, weight loss. I know that's very non-specific, but something that is very indicative is going to be following HBV infections, so hepatitis B. The big thing that you guys need to highlight and remember is the lungs are spared in this disease. So polyarteritis nodosa, there we go, lungs. Lungs are spared. That is a huge thing about this disease because a lot of things are affected, but not the lung. So highlight that, star it, remember it for your exam. Then your histo, you're going to see transmural inflammation and then the fibrinoid necrosis. Kawasaki disease. This is endemic in Japan and it's going to be kids. So you in the vignette, you're probably going to see something along the lines of a young kid from Japan. It's going to come in with fever. They typically have cervical lymphadenopathy. You'll have conjunctival erythema. So the eyes are going to be red. Strawberry tongue, that's a big one there because that's very specific to this. And then hand, feet, edema, erythema, and rash. So big, there is a risk for aneurysm, rupture, hemorrhage, and MI. And this is a delayed hypersensitivity reaction. And the autoantibodies are to the endothelial cells and the smooth muscle cells. Berger's disease, I remember they did one of these in one of the clinical skills small groups. So young male, extensive tobacco history. Tobacco is the biggest thing here. So it's, I think they call it like hypersensitivity to tobacco or something along those lines, but tobacco is the biggest main risk factor here. So they're going to come in with classic Raynaud's. So the fingers turn white when it gets cold. And then pain in foot. So that's another claudication, pain in foot when you walk. And then, so what leads to, so over the progression, you get thromboangiitis obliterans. So what happens is you get ischemia and infarction of the digits and then ulceration and gangrene of the distal digits. Wegener's, for all of these small vessel vasculitides, know what it's mediated. So Wegener's at C-ANCA, PR3 ANCA mediated. Here you are going to see symptoms of upper respiratory infection, lower respiratory infection, and you're going to see renal involvement. So any combination of any of these, I remember perforated nasal septum. That was a weird one, but it stuck out to me, and I feel like I saw that on the exam. But just know that it has upper respiratory, so sinuses and everything, but lower respiratory, lungs, and then renal involvement. So you're going to see characteristics from all three of these sites. So the actual disease, you're going to have a triad of focal necrotizing vasculitis, necrotizing granulomas, and necrotizing glomerulonephritis. So this is very rapidly fatal. I don't remember if it was in lecture or if it was a supplemental video I was watching, but it's a reaction and it's very fatal quickly. And so, but you can see a rash appear, just all of a sudden appear on the patient. So if you treat quickly with corticosteroids, the patient can make a full recovery and be good. But you'll see all of this stuff that it's affecting, necrotizing vasculitis and granulomas. They can pass very quickly. So it's important that you see this. It is immune mediated, I believe. And then Churg-Strauss, P-ANCA, MPO-ANCA. Again, need to know that for all of it. This is allergic granulomatosis. So anytime you see anything associated with allergic, you're going to see eosinophilia and you're going to see association with IgE. So you're going to have raised IgE. This is still granulomatous. So the patient will present, they'll have recurrent asthma attacks, sinusitis, skin nodules, peripheral neuropathy. No, look at the ANCAs. And then microscopic polyangiitis. You're going to have hemoptysis, which is coughing up blood, hematuria, blood in the urine, proteinuria, GI bleeding, myalgia, weakness. So this is going to be more after so after penicillins. That's what PCN stands for, penicillin, and then infection. So you do not have granulomas or eosinophils, but this is still a hypersensitivity reaction. Okay, moving on, cardiac hypertrophy. So hypertrophy, this is a compensatory change. The heart just doesn't decide, oh, hey, I feel like I'm going to grow today. No, it's a compensatory mechanism to stress. And so you have concentric and eccentric. So concentric is going to be pressure overload on the ventricle. So hypertension, aortic stenosis, my God, Liz. Aortic stenosis, because aortic stenosis, you're not going to have the stroke volume. So you're going to get the blood coming back into the heart. So you just have a pressure overload. So sarcomeres are added in parallel. They're stacking on top of each other due to the pressure that they are having to endure. But that makes sense versus eccentric, because if you had a lot of pressure, you want to thicken so that you can withstand that pressure, versus eccentric is due to volume overload. So what you're trying to do, you're adding them in series so that you have a bigger area to fill a larger volume. So in aortic regurgitation. Heart failure, the gist, Brady did a very nice big overview. I condensed it down. So the gist, the heart can't pump enough blood. That's what it is. No matter what type of heart failure you have, the body is not getting enough blood to keep up with nutritional and oxygen demands. This is the end point of a lot of cardiac diseases. So again, this doesn't just happen overnight. You have a very steady chronic increase, and then you get to this point when the heart can no longer compensate for all of the stuff that's happening. So it's called CHF, congestive heart failure, because backup of blood causes congestion. So we'll talk about left versus right heart. Okay, so systolic can't contract versus diastolic, it can't fill and relax. Again, if you systolic, you're going to have myocyte loss. So for example, after a heart attack, and then you're going to have pressure overload. You can also have pressure overload during due to hypertension. We talked about volume overload due to valve regurgitation, and this can cause that eccentric hypertrophy versus diastolic. And we can have, you're going to have pressure, because if you can't relax and fill well, you have increased pressure, and so you can have the concentric hypertrophy. Left-sided, so left ventricle is failing. You see this in hypertension. You can also see this in mitral and aortic valve diseases, ischemic heart diseases, and cardiomyopathy. Right-sided, the right ventricle is failing. This is due to diseases of the lung parenchyma vasculature. COPD is a really big one. Cor pulmonale, you know that all of this is due to lung defects. And so if you have a right-sided heart failure, it's most likely because something's going wrong in the pulmonary system. And then high output versus low output, but we already talked about all that stuff. So again, compensated. Initially, the heart's going to change and react so that you can maintain the cardiac output. But over time, this becomes burdensome and the myocardium fails and can't propel blood. So how are they going to present? Left heart failure, it's going to back up into the lungs. So it goes right heart system, right heart, lungs, left heart. So if the left heart fails, then it's going to back up into the pulmonary system. So that's when you're going to get the shortness of breath, orthopnea, and paroxysmal nocturnal sleep. So histologically, you're going to see congestion of the pulmonary or alveolar capillaries. Then right failure, again, it's backing up into the systemic system. So you're going to get jugular vein distension. You'll see hepatomegaly. They call it the nutmeg liver. You can see splenomegaly because it's all backing up into the systemic system. And then, of course, peripheral edema. Okay, ischemic heart disease. This is also known as coronary artery disease because it's causing the ischemia. So anything that's causing an imbalance between blood supply and then oxygen demands of the heart. Most common cause, again, atherosclerosis, because over time, not only are you narrowing the lumen because of a plaque, but you are narrowing the lumen because of possible stenosis of that lumen because of the plaque there. So you can have inadequate blood flow even at rest, which is a bad thing. So a thrombus, which is rupture of the plaque, you can lead to obstruction of flow. If it's complete, you can get a heart attack. If it's incomplete, angina. Classical presentations, angina versus acute coronary syndrome. Angina, it's not as concerning as a heart attack. So you have stable and principal variant. And then unstable angina is under the category of acute coronary syndrome, and then NSTEMI and STEMI, which those are heart attack. And we're going to go into all of those. So angina is a recurrent attack of chest pain due to ischemia, but this is transient ischemia. This doesn't lead to necrosis. So the reason you have pain is because this ischemia is going to lead to release of adenosine, bradykinin, which then stimulates the sympathetics, which will follow vagal afferent nerve. So notice that there is a difference in presentation and cause in each of these. That'll help you distinguish, okay, which one am I talking about? Stable, typical atherosclerosis is the big thing. So they're going to have exertional chest pain. And so that gets better with rest or nitroglycerin, so any sort of vasodilator. If you do a stress test, you can see ST depression, but you're not necessarily going to see it in the moment. You have to, exertional chest pain, you have to elicit that response. You're also not going to see a rise in cardiac enzymes because this is only ischemia, no infarction. If you have less than 30 minutes of ischemia, then it's reversible and it can go back if you don't have any damage, and you're not going to see the after effects like you would in a heart attack. So less than 30 minutes, only ischemia. You're not going to get myocyte disruption, so it's not going to leak out the enzymes. So atherosclerosis, exertional chest pain, that gets better. Principal or variant, this is due to vasospasm. So the risk factor here is smoking. So this is pain at rest. So a typical presentation is a person that wakes up in the middle of the night with this chest pain. So awoken from sleep with chest pain. So remember, this is at rest. So this is just a vasospasm. And the vasospasm, of course, is going to cause the ischemia because you're not getting as much blood flow. So you will see transient ST elevations, but again, since we don't have that 30-minute threshold, you're not getting disruption of the myocytes, you're not getting the enzyme leakage into the serum, so there's no measurable cardiac enzymes that you're going to get. Now, acute coronary syndrome, this is where you get into the bad territory. And unstable angina, this is due to atherosclerosis, but this is a disrupted plaque. So this is an unstable plaque that has ruptured, and you now throw a thrombi. So now unstable angina is an incomplete coronary artery occlusion. You're not getting the complete occlusion, but you are getting some. So what this is going to present with is pain that gets progressively worse with progressively less effort. So if 1 week you started getting chest pain when you were, ran a mile, versus the next week you started getting chest pain when you just ran a few yards. So chest pain is getting worse with less and less and less effort. So this will still respond to vasodilators, for example, nitroglycerin. This is pre-infarction. So you still have an occlusion. It's not complete occlusion, but you still have an occlusion. So this has a high incidence of subsequent MI, because if you don't take care of the problem, you can get a complete coronary artery occlusion. This is just kind of like the preview to the chest pain. So you can see ST depression and T-wave inversions, but again, we only have ischemia. We don't have tissue cell death right now. So we're not getting the cardiac enzymes. Now, if you have prolonged ischemia, so 30 minutes or more, you're going to get the tissue death. And that's when you're going to have the disruption of the myocyte cell membranes. Then you're going to get leakage of the cardiac enzymes into the serum, which is when you can measure the cardiac enzymes, which is an indicator of myocyte cell death. Risk, atherosclerosis, rupture of that plaque, giving you the thrombosis. Thrombosis then has complete occlusion. So you're not getting anything past that occlusion. That's why you have the ischemia and subsequent tissue cell death. So STEMI versus non-STEMI, the difference between these two is the EKG findings. So ST elevation MI versus non-ST elevation MI. A STEMI is going to be full thickness versus NSTEMI is going to be just the inner third of the ventricular wall. So it's transmural versus just that inner third. So patient's going to present with retrosternal crushing chest pain. A really common description that patients like to use is an elephant sitting on the chest. So pain rating into the jaw, left shoulder, epigastrum. Again, longer than 30 minutes because 30 minutes is kind of the threshold where you're going to get that cardiomyocyte death, and then not relieved with nitroglycerin. Again, this is a complete occlusion. So vasodilation is not going to be able to adequately reperfuse the heart. And then shortness of breath, rapid weak pulse, diaphoresis, and nausea, vomiting. Okay, this is extremely high yield, and I'm going to point out what I want you to know at each of this. If you haven't already started using first aid religiously, I would highly recommend so, because it has a lot of really good, it organizes it very well. Okay, so in the first 24 hours, coagulative necrosis, associate that with this. And then you can get reperfusion injury. So what this is, you basically get release of free radicals and you get an increase of calcium influx. So this stuns the myocardium. It goes into all of the myocyte, all the sarcomeres are going to go into tetany. So it's the stunning of the myocardium. That's what reperfusion injury is. Like, oh crap, oh, it's here now. So we contract and everything's in tetany. That's what reperfusion injury is. But the coagulative necrosis, that is due to the cell death. So coagulative necrosis. And then big complications. Remember, they love risk factors and complications. So pay attention to every single complication. So you can get ventricular arrhythmias at this point. So if you are having infarction at an area in the ventricle, you can no longer pump well. And so if you get aventricular arrhythmia, that is the most common cause of death in the first 24 hours after a heart attack, because the heart is not going to have the same electrical what word am I trying to use? It's not going to be able to electrically handle itself. So ventricular arrhythmias is the most common cause of death in the first day after a heart attack. Then 1 to 3 days, you still extensive coagulative necrosis. You get a lot of neutrophilic infiltration. What can happen here? You can get a post-infarction pericarditis right here. So this is just like an overwhelming amount of neutrophils that's coming in here at 1 to 3 days. And then the neutrophils are cleared and by macrophages, and you get granulation tissue. Now, this is where a lot of bad stuff happens. Why? Because granulation tissue is very weak. It's immature. It hasn't gained structural integrity. So you can get a lot of stuff here. You can get free ventricular wall rupture. How does this patient present with tamponade? So you're going to have distant heart sounds. You're going to have a low blood pressure. And there's one more thing, but that's a big one. Free ventricular wall rupture, 3 to 14 days, because this granulation tissue is extremely weak. Papillary muscle rupture. So you can get mitral regurgitation. So 1, free wall rupture leading to tamponade. 2, you get papillary muscle rupture, which is going to lead to mitral regurgitation. You can get interventricular septal rupture. And then you can get a pseudoaneurysm. So there's a lot of stuff that can happen because this granulation tissue has so much less structural integrity than it used to.
Hey, Lindsey.
Yeah.
Lindsey, you brought up a really important point. Can you go back to that slide? Because this question keeps coming up, right? They're going to tell you a patient had a myocardial infarction. They were sent home. About 7 to 10 days later, they present with dyspnea, difficulty breathing, and then they give you that triad: hypotension, muffled heart sounds, jugular venous distension. Okay, they're going to ask you what happened. You're going to be like, well, the patient has cardiac tamponade. Why? Rupture of the free wall of the left ventricle. Literally, the left ventricle tears open, and all of the blood goes into the pericardial sac. Okay, so we've had this. It's coming up again now that we're talking about it, but make sure you know that, because y'all probably get a test question on it.
Yeah, definitely. You definitely will, probably. Okay. So 2 weeks to several months later, you have a complete scar now. So the thing here, you can get Dressler's syndrome. So this is an autoimmune reaction that occurs 10 to 14 days. It's autoantibodies directed towards the pericardial antigen. So Dressler syndrome at this point. And then a very late complication. So we're talking like a year later, a very late complication is ventricular aneurysm. So, so complication of large transmural infarct. So that would be a STEMI, ST elevation, a myocardial infarction. So scar tissue, of course, it's not going to have the same structural integrity. It's going to bulge during systole. You can get a mural thrombus, highlight that word. Arrhythmias and heart failure can occur. Now, what can you do to test for MI? The first biomarker is myoglobin, but this is not specific at all. So this is not used. So no, it exists, but the likelihood of them testing you on it because it's not used is kind of low, but no, it's there just in case they want to throw it in on you. Troponins, of course, are the most specific and they will rise and stay risen for a few days. And so a patient can come in a week later and they will still have troponins elevated. Now, what happens if they have a new heart attack? How do you know? Well, it's the CKMB. CKMB rises for a lot of reasons, but it's a good indication of reinfarction because it's going to go away quickly. It's going to rise kind of with the troponins right after the troponins, but it's going to go away very quickly. So if a patient comes back in a week, they have similar pain to what they had and they had a heart attack, troponins are still going to be up. But if CKMB is high, then you know that they're having another heart attack. Something else that's going to be increased, lactic dehydrogenase. Why? Because myocyte death, remember that why are we even getting these serum markers? Well, it's because the cells died, the cell membrane was structurally damaged, and then you're releasing all of these things into the serum that you can measure. One of those things is lactate. So you will see an increase in LDH. And then EKG, what can you see? STEMI, you're going to see ST elevations, pathologic Q waves, which are going to persist. You'll learn this in term 5, but if you see a Q wave on an EKG, it's indication of a past MI, but for your purposes right now, I don't think that's a huge thing. And then NSTEMI, so it's non-ST elevation, so it just, you're not going to see that, but you can see a T wave inversion. And then chronic ischemic heart disease. So again, remember, heart failure is going to be the end point of a lot of cardiac issues. So if you have chronic ischemic heart disease, Brady talked about, you can get MI, or you can get a lot of anginal attacks because anginal attacks are still causing stress on the heart. You can get heart failure. Decompensation. Good tissue. Oh, I know what I was trying to say. You can have decompensation because the good tissue gets tired. So you have dead tissue after an MI, you get that scar. The scar doesn't have the same structural integrity, nor does it have this electrical integrity that it used to. So all of the good tissue that's remaining in the heart has to work a little bit harder to compensate for the loss, but that tissue is going to get tired because now they're having to do more work over time. So you can get decompensation and you're going to get chronic ischemic heart disease. And then it's severe obstructive disease. So you have diffuse dysfunction. Sudden cardiac death, just unexpected death without symptoms. This is the most common cause is going to be coronary artery disease in adults. What is the mechanism? You're going to get left ventricular fibrillation. That's another hand dyslexia there, but that's the most common cause of sudden cardiac death is the left ventricular fibrillation. Valvular heart disease, we're going to go into these. So all of these are valvular diseases. So you have your murmurs that we've gone into before. So aortic stenosis and regurgitation, mitral stenosis and regurgitation. And then rheumatic fever can affect the valves, and so can infective endocarditis. So briefly going back over these, So mitral stenosis, a big thing that's in rheumatic heart disease. We'll talk a little bit more about that later. Aortic stenosis, this is more wear and tear. So this is calcific aortic stenosis. This isn't necessarily due to any specific pathology. It's just wear and tear. And so like Brady said, if you have an older patient coming in, they have this murmur, you can probably say that they have aortic stenosis. Mitral regurgitation, a lot of things can actually lead to mitral regurgitation. And then aortic regurgitation. These are your symptoms and signs for these. We'll hit really hard later on aortic stenosis and mitral regurgitation. That's why I'm not sitting on these slides for very long, because this is kind of the reintroduction of these concepts to you from CPR, but it goes into more detail in aortic stenosis and mitral regurg later. So rheumatic heart disease, this is big, 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 big. You need to understand this. So the patient is going to come in with a past strep infection. So strep pyogenes is the biggest one. So highlight that. It is going to be a type 2 hypersensitivity reaction. And the big thing here, again, highlight molecular mimicry. So the antibodies to M proteins. So this is the molecular mimicry. And that's why you're getting this autoimmune reaction. Mitral valve, this is the most commonly effective, then aortic and tricuspid. So if you have chronic rheumatic heart disease, you can end up with mitral stenosis. Remember I told you histo is your friend in year 2, so Ascough bodies and I don't know how to pronounce that, but I put a picture I found on Google on the right. But if it mentions either of these cells, you know you're talking about rheumatic heart disease automatically. It's a buzzword. Also big I forgot what that stands for, but ASO and then anti-DNase B in serum. And then Jones criteria, these are the major criteria. So this is what you're going to see in the presentation. You're going to have migratory polyarthritis in mainly the large joints. And then you're going to have a carditis, nodules in the skin, erythema marginatum. I feel like the rash was such a huge thing that they focused on in the case. So that's what can clue you in on. And then synonym chorea. Complications, again, complications are really big. You can have a lot of things that come from this. But biggest things you need to focus in on: group A strep, molecular mimicry, proteins, the Ascough bodies, and then the serum. Calcific aortic stenosis, again, this is wear and tear, or another cause can be a congenital bicuspid valve. So highlight that one too. So repeated hyperlipidemia, hypertension, and inflammatory injury to the valve, you're going to get degeneration. And then you have the deposition of the hydroxyapatite, which of course then impairs the structural integrity, and you get this stenosis. So what are you going to see? These calcified masses on the outflow surfaces of the cusps, but the free edges are not involved. I feel like that was something that they hit on for us. And then the clinical features down there, you have this triad of chest pain, syncope, and I can't read the last one there because my Zoom is blocking it off. But that's your clinical presentation if they start talking about this. Congenital bicuspid is a risk, or wear and tear. Myxomatous mitral valve. This is mitral valve prolapse, so connective tissue defect. So patient will come in, they'll have palpitations and fatigue and chest pain. The biggest thing you're going to hear that mid-systolic clit is because this is a systolic murmur. Then complications, you can have mitral regurgitation, CHF, and then infective endocarditis, and then the arrhythmias, which the ventricular arrhythmias are going to be the cause of sudden cardiac disease.
Hey,
Infected,
Lindsey,
yeah.
and I just wanted to point something out that I found confusing. It took me a while to kind of grasp this. So when they talk about things that increase preloaded, increase afterload, such as like when kids have tetralogy of Fallot and they squat down. So they're going to talk about these murmurs when the questions get a little more complicated. They're going to talk about things that increase preload, increase afterload, and those are always going to make the murmurs louder, right? That should make sense. Anytime you have more blood going to the heart that are going through those diseased valves, or anything time you have afterload, and take a regurgitation, for example, there's more blood that's going to regurgitate. So anything that increases preload or afterload is going to increase the sound of the murmur, except in mitral valve prolapse. It's not super important why, but with mitral valve prolapse, it's opposite. So anytime you increase preload or afterload, it'll actually decrease the sound of the murmur. So take, for example, doing the Valsalva maneuver, that's actually a process of decreasing preload, okay? So if they say a patient does the Valsalva maneuver and the murmur gets louder, it's mitral valve prolapse. Okay, so just for completeness sake, hypertrophic obstructive cardiomyopathy, if y'all come to that and mitral valve prolapse are opposite, okay? So all murmurs will get louder with increased preload or afterload, except MVP and hypertrophic obstructive cardiomyopathy. That'll help you answer some of the more difficult questions.
Yeah. Okay, infective endocarditis, infection of the heart valves. There is a difference between acute and subacute. Acute is a rapid onset presentation. This is a previously normal valve, and it's S. aureus vegetations, and this is very common in history of IV drug abuse. So that's a buzzword right there, history of IV drug abuse. And then subacute, slow onset, most likely viridin strep Tococci, and then something here, common sequelae of a dental procedure. So look in the patient's history, because the history is going to be very indicative of what you can expect for it. So the hallmark of this, you're going to have vegetations on the heart valve, which make the valve friable and bulky. And these vegetations are going to contain fibrin and inflammatory cells and bacteria. They can erode the underlying myocardium, and they're going to form ring abscesses. And these are also prone to embolizations because it's this foreign material there. So it can fragment, and you can get the virulent organism to a distant site, and it can cause mycotic aneurysms at a distant site. Now, remember, we talked about the different types of organisms. We talked briefly about mycotic aneurysms. And so how are you going to get those mycotic aneurysms? Because it's a thrombus, it's embolized from a vegetation on the heart valve and infective endocarditis, and it can seed. And when it does that, it's going to compromise the structural integrity of that area. There are some others. So we talked about strep viridans, and we talked about S. aureus. Strep bovis is associated with colon cancer for some reason. And then you do have this I don't know how to say it, but this other group, so commensals of the oral activity. But we're going to go over this more when we get into the micro stuff. This is more of just an introduction to this. So this is the pathogenesis of this. Oh, I put this on here because of the symptoms. So you can have various symptoms with infective endocarditis. So constitutional, of course, because if you have an infection in the system, you're going to have fever, you're going to have malaise, and then inflammation, increase ESR and CRP, arthralgias, myalgias, all of those things. Yeah. Okay, so more highlight these. You're gonna have clubbing of the fingers, you're gonna have splinter hemorrhages, Osler's nodes, Janeway nodes, Roth spots. If they mention any of these, which they most likely will, or they'll describe them. So I'm giving you the names. They might describe them to you instead of telling you what it is. So tender subacute nodule, non-tender macula on the palms and soles. That's gonna clue you in on, okay, this is infective endocarditis. So again, you have acute and subacute, which are going to have different presentations. And then how do you diagnose this? Is the modified Duke. So if I remember correctly, they'll ask you like, how would you confirm this diagnosis or something along those lines, or which of the following would help you? I don't remember, but just understand the modified Duke criteria. Okay, non-bacterial thrombotic endocarditis. So this is going to be a sterile thrombi. So remember, in the infective endocarditis, those vegetations did have the organisms inside. So I had the fibrin, they had the leukocytes, and they had lymphocytes, and then they had the organisms. So this is a sterile thrombi. Again, complication, you can't have embolization, but you can also get infective endocarditis down the line. So this is eosinophilic materials are going to have fibrin in there, aggregated platelets, loosely attached, the cups loosely attached, so you can get the embolization. And you do not have association of the surrounding tissue. That's important too. The last couple, this one, it didn't have a lot on there. I don't even think we were asked about it, but of course, for completion's sake, these are also sterile vegetations, but this is in the setting of lupus, in the setting of SLE. So just understand that you can have sterile vegetations in this. And then it's going to be a consequence of the immunocomplement deposition, and then you get subsequent activation of complement. So that's what it's associated with. And then prostatic valve disease, I think I put in this on here for completion's sake. But they talk a lot more about the significance of this in the micro slides. And then, yes, please understand that all of these are going to have different distributions of the vegetations on the valve, and it is important. So rheumatic heart disease is along the lines of closure. Infective endocarditis, it's on the cusps and can extend to the chordae tendineae. NVTE along the lines of closure, and then LSE is on both sides of the leaflet. Okay. So systemic hypertensive disease. Okay, so early asymptomatic, because you're remember, malignant hypertension is going to be a very steep increase in blood pressure, and you're going to automatically get damage from that. But if you have benign hypertension, it happens over time. So your body has time to compensate for what's going on. So early stages are going to be asymptomatic because your body has a lot of time to adjust to it. Angina, signs of left heart failure. I don't remember why I put this on here. Okay, but concentric hypertrophy of the left ventricle. Remember, concentric hypertrophy is due to a pressure overload. So you are going to get a thicker wall to accommodate for the pressure. And then long-standing, you're going to get right ventricular hypertrophy, because if your left heart fails, your right heart's going to fail too. And then the boxcar shaped nuclei in the myocytes is big from that. Okay, versus pulmonary. So also called cor pulmonale. So this is heart disease caused by a pulmonary, the origin of the disease is pulmonary. It's not from the heart. You're gonna have a defect in the right cardiac chambers. So pulmonary parenchymal disease, pulmonary vascular diseases. So when you get that congestion, it backs up into the heart, and that's why you're getting that. Acute cor pulmonale, again, that's just saying that this is due to the lungs. COPD is a big cause of this. Highlight that. They love to focus on that. Okay, I forgot to put more on the slide because I was going to go to the micro and then back to this. but there's like one slide on each type of the myocarditis. Just go through there. It's not complicated, but when it talks about the micro, which we're going to go over later, that's where it gets deep, and that's why I apologize. I didn't finish that slide. Then you have cardiomyopathy, different kinds of cardiomyopathy. So this is just disease of the myocardium, and it's due to mechanical or electrical dysfunction. There are different types. Dilated. So you have people upstairs are being loud. So progressive dilation, and if you have dilation, you're also going to get systemic dysfunction. So you have left ventricular hypertrophy. Again, if you have hypertrophy, that's a compensation over time. You're going to get decompensation. You can get heart failure. So this is autosomal dominant inheritance pattern. So you can get mutations in the cytoskeletal proteins, or it can be X-linked, and it can mutations in dystrophin. A big risk factor is alcohol. If you have viral dilated cardiomyopathy, a big one is Coxsackie B, and then a complication, mural thrombus, due to contractile dysfunction. Arrhythmogenic right ventricular, so inherited, it can cause sudden cardiac death. The mutation is in the desmosomal junctional proteins, which is plakoglobin. So the desmosomes can detach during exercise, and you can get cardiomyopathy. Then hypertrophic cardiomyopathy, and then restrictive. For restrictive, it's essentially anything that's going to cause an actual obstruction of the pumping of the heart. So amyloidosis, sarcoidosis, radiation-induced fibrosis, so anything that can restrict the pumping action of the heart. Okay, so hypertrophic cardiomyopathy, just more information on this. So again, gain of function mutations. The big thing here is you end up with myofiber disarray. That's a big, highlight that, star that, and then fibroblast proliferation. So the big thing here is you can get sudden death. Pericarditis, this is disease of the sac surrounding the heart. If it happens over time, heart can accommodate. Again, just, same with hypertension. If given time, you have this slow accommodation. But if there is a sudden change, for example, a hemorrhage, rupture, where you get accumulation in the sac and you get compression. So this is an inflammation, so a sudden change. And so you are going to get compression on the heart. And so the patient is going to present, the chest pain is going to get worse when you lean back and relieve when you move forward. And something that's indicative of this is a high-pitched friction rub. And this can progress to chronic pericarditis, where you can get right-sided venous dissension and low cardiac output. Okay, congenital heart diseases. I put this on here as more of an introduction, but understand the pathology behind right to left and left to right-sided shunt, because this is going to determine what these symptoms are in the presentation. So if you have left to right, you're increasing the pulmonary flow because it's not getting to systemic circulation. And so pulmonary artery undergoes fibrotic intimal thickening. That's the compensation right there. And then you'll have medial hypertrophy and vasoconstriction. You can get pulmonary hypertension later, and then right ventricle is going to be hypertrophied. But then right to left side of the heart, this is where you're getting the hypoxia and cyanosis, because you're bypassing that pulmonary circulation. So left to right shunts, you have the ASDs, which is an opening in the atrial septum. VSD is incomplete closure. Big thing here. It's associated with the trisomy, so 21, 13, 18. You can get pulmonary hypertension, CHF, but you're going to hear a pansystolic murmur. If you see in the vignette that the pansystolic murmur, it's going to clue you in on the VSD. If it is large and it does not close, you get an irreversible pulmonary vascular disease. If you have shunt, not sunt, shunt reversal and cyanosis, that's called the Eisenmenger complex. And then PDA, in utero, it allows blood to bypass non-functional lungs. You don't want lungs to perfuse, you don't want blood to perfuse lungs that aren't being oxygenated. That just won't be good. And so, but after birth, it will close within 1 to 2 days. But a persistent ductus arteriosus is associated with rubella infection in the mother. Highlight that, star it. That's a big one. And the vignette is going to show a harsh machine-like murmur. And then you can give indomethacin to close up. Right to left, the chalagia below, the 3 characteristics. You have VAD, subpulmonic stenosis, overriding aorta, and then right ventricular hypertrophy. Big association with Downs is your risk factor, and then you can it can lead to an increased risk of infective endocarditis and embolization. Transposition, so aorta and pulmonary artery kind of switch where they're coming from, so you create this parallel circulation. This is incompatible with life unless you have a shunt to provide mixing, because the thing is you're not getting oxygenated blood to the systemic circulation, and so you have generalized hypoxia. And then truncus arteriosus, failure of partitioning. Okay, obstructive congenital disease, malformation, coarctation of the aorta, again, associated with Turner's. Anytime we have that, it's big. So coarctation risk factor, it's associated with Turner's. So 2 types, preductal versus postductal. The biggest thing here, just that association. Cardiac myxoma, cardiac tumor that can fragment and embolize. Big thing here, this can cause an obstruction of the AV valve, which can lead to syncope and sudden death. Metastatic tumors, they're always to the heart, they're not from the heart. So you can have a primary tumor in the lung, breast, melanoma, leukemia, lymphoma, and then it can you can get mets from those cancers that go to the heart. Renal path, nephrotic versus nephritic. I don't know why in term 4 this took me so long to understand. We're going over it again now. I'm like, this just makes so much more sense. So nephrotic, I remember this because nephrotic, ROT, proteinuria, but essentially you get podocyte damage, so you have an impaired charge barrier, and the biggest thing is you're going to have proteinuria, so it's more than 3.5 grams daily. So that's going to be your big thing. If you're looking at the vignette and they have the more than 3.5, it's a nephrotic syndrome. You're going to have, now if you have protein coming out in the urine, conversely, you're going to have hypoalbuminemia. So you're going to have low protein in the blood, and then you get edema. Why do you get edema? Well, you're losing all your protein in your blood. And remember, protein is one of those things that is involved in the hemodynamics. So if you don't have any protein in the blood, then all the fluid is going to come out of your blood into the interstitium, and that's how you're going to get edema. So it makes sense. Protein's leaving your body. You don't have protein in your body. Hemodynamics are messed up, and you get fluid leaking from your vessels into the interstitium, causing edema. So patient comes in, they have edema, they have proteinuria, and then whatever other characteristics of the individual disease. But that's why you have this kinds of presentation. You're also going to see lipiduria in the form of fatty casts. So the urine is very likely frothy with fatty casts, and you will see hyperlipidemia. And these patients are also going to see an increased risk of infection and thrombosis. Why? Because not only are you losing protein in your urine, you're also losing antithrombin 3 and IgG in the urine. So antithrombin 3, now you're going to be in It's going to lead you to thrombosis more likely than IgG, of course. Then nephritic, so this is more inflammation of the glomerulus. Then you get glomerular basement membrane damage, and so you're losing red blood cells in the urine. So you're going to see gross hematuria. You're still going to have loss of protein, but it's not going to be in that nephritic range, so it's going to be below 3.5. Other big features, you're going to have a decrease in GFR, leading to oliguria. Oliguria is just a decrease of urine output. This makes sense though, because if your glomerulus is damaged, you're not getting good filtration of the blood. And so you're going to have a decreased GFR, you're going to get oliguria. And then because of this, because you're decreasing GFR, because you have this, you're going to get increase in the renin release, and then you can get hypertension down the line. So let's go over the minimal change disease. I pulled out the different pieces of information that you need to know. So minimal change, look for a kid that
Hey, Lindsey,
had, yeah.
let's take a little break.
Oh, okay.
And then what I think we should do, let me go through, so you can have a break. Let me go through the cardiac drugs and stuff, and then we'll go to the renal stuff. Okay,
sounds good.
Let's take a 5-minute break for you guys, and then we'll come back. You did great. All right. Now, Lindsey's very nice to you guys and made slides. I'm just gonna go through my notes that I had from last term. I did go ahead and post all of these so y'all could see how I highlighted everything, but we're gonna go pretty quickly through this just because we wanna get to the renal stuff too, okay? So some of this is overlap, right? So we talked about the infective endocarditis, we talked about rheumatic heart disease. Just remember, what you need to remember is pretty much what the first line bacteria or causal agent is for these different lesions, right? And remember, affective endocarditis, Osler's nodes are tender, Janeway lesions, hands and palms are going to be non-tender, and raw spots show up in the eye. So they'll typically give you that for infective endocarditis. I used to make a big deal of trying to remember this criteria, but I've never come across problems where they're like, did they technically qualify with the major and minor? So, that's my 2 cents on actually learning these like this and stuff. So, right, so this would be a very important slide for the native valve endocarditis. What's going to be most common? Remember, they like to talk about IV drug users. Remember, that means they're injecting, they're using a needle to inject directly into their venous system. So that Staph aureus that's on your skin gets in there. The first valve that Staph aureus that was recently injected gets to is the tricuspid valve. So classically, if they talk about either an IV drug user, or sometimes I'll say people that are on hemodialysis, because they have to get a lot of, to do hemodialysis, you have to have venipuncture. So they'll talk about that valve. It's typically staph, right? Okay, so here when we're looking at endocarditis, we have strep, enterococcus. Those HASEC organisms are like 5%, not terribly important. And then prostatic valves, you could see the staph is very common here. Even the coagulase negative ones. Remember, strep viridans, if they ever talk about a patient that had a recent dental procedure, they have to be and they have a heart valve transplant, they have to be on significant prophylaxis, okay? Because that strep viridans in the mouth is can lead to infective endocarditis. I think they're having a party outside. I don't know, in my apartment. Anyway, yeah, so you see here, staph and strep are the big ones. So if it came down to it, pick between those two. All right. And then these are just characteristics of the bacteria that you learned about before. And then these are strep viridans, mutans, and sanguinis. And remember, those are dental procedures or bad dental hygiene. All right. All right. Let's see. Yeah, so rheumatic heart disease. Remember, you have typically a kid had a recent sore throat, week or so later, getting heart problems. It's that molecular mimicry. Remember, when you go and test these kids to see if they have rheumatic heart disease, they will not have strep pyogenes in their blood, okay? The blood cultures will come back negative. It's very important because the strep pyogenes is not causing the actual damage to the heart valve, particularly the mitral valve. It's actually this molecular mimicry. The body makes autoantibodies that attack the valve, similarly to if rheumatic heart, or excuse me, if they would attack the valve similarly to if strep pyogenes was there, but the blood cultures will come back negative. Okay. You can see enterococcus also, right, both different valves. What did we get to? Okay, let's see. And then these HACCP organisms too, right? So those are very, 5%, so not terribly important, but if they come up. All right, and then myocarditis, you can see here, it's obviously the muscle tissue. Viral causes, you need to think of Coxsackie B. B is for body, Coxsackie A does like hand, foot, and mouth disease. So remember Coxsackie B is the big one here. They have fungal causes. Remember, fungal infections, typically the patient has to be immunocompromised. So if they say immunocompromised, they're probably leading you down the road to go to a fungal infection. Trypanosoma, Chagas disease. Remember, when I think trypanosoma, I think dilation. It causes dilated cardiomyopathy. Okay, so that's what that's going to cause. In South American Chagas. Toxoplasmus as well, immunocompromised. That's when we talk about, isn't that the cat? I think that has to do with the cat feces, toxoplasm. Yeah, I think so. Don't correct me if I'm wrong. Okay, pericarditis. Remember, if you have this friction rub, when you listen to the stethoscope, with the stethoscope, it feels scratchy. You can get effusions there. Typically they'll say the patient feels better and relief when they're leaning forward. Okay, that's classic for pericarditis. You can see both Coxsackie B, A and B there, and then some other viral causes classically. Even some immunocompromised, some fungi and stuff. All right, and then here would be a good summary slide for everything. All right, cool. Now, if y'all were like me, the diuretics kind of made sense, so we'll go through those quickly. I think what I had the most trouble with was their antiarrhythmics. Now, in term 5, we actually went through all of the arrhythmias and looked at them with EKGs. So why they teach you the antiarrhythmic drugs in term 4 and you actually learn the arrhythmias in term 5, I don't know. But when we get to the antiarrhythmics, I will tell you what you need to know for the questions that they're going to ask. Because I went into the exam being like, if they tell me it's like atrial fibrillation, I don't know what drug to give. But that's not how they tested. They tested on saying like, which one prolongs QT, and like you want to give one that is good for extending QRS. So that's what we'll look at there. But quickly we could run through the diuretics. So remember, diuretics, good for the heart, good for your vessels. You got to get the fluid off. Good for the renal system as well. So that's why cardio and renal are together, because they kind of work in conjunction with the whole volume regulation. Okay, so typically when we talk about either heart failure or renal problems or hypertension, the first line drug you want to give is a diuretic. All right, so let's get to the actual drugs. Now, loop diuretics are super strong. Okay, so they're not first line, but if a patient comes in a congestive heart failure, like full blown, like left heart failure, has dyspnea because there's fluid in the lungs, has right heart failure because of that, and now has peripheral edema, you just give them a loop diuretic. You give them furosemide, that's Lasix. You give it to them right away because you need to get all the fluid off. But when you're talking about just regulating high blood pressure, you don't give a loop diuretic first. They'll bottom out, right? They'll get orthostatic hypotension. It's not a first line for that. But when you think about heart failure and all of the peripheral edema, you definitely want to give it. So when you think of loop diuretics, think of it being really strong, okay? So management for edema. Just a good thing to know, they are used on these channels here, the sodium chloride potassium channel, this co-transporter. Okay, and they obviously work in the loop of Henle. Super important to know these. You know, my highlighting by now probably, you know, red is super important, green's, you know, a little less important, and yellow's a little less. So some of these are going to be more important than others. And a good thing that they actually increase renal blood flow down the line. That's you learn about that in term 5. So let's see. Obviously, these adverse effects are going to be super important too. Ototoxicity, okay, it changes the fluid balance in the ear canal. So ototoxicity is a big one. And then some of these other ones, you definitely want to remember these hypokalemia versus some of the diuretics that work downstream are going to be potassium sparing, okay? And watch out for the allergic reactions with sulfa drugs. Okay, so good little explanation here. All right, so thiazides, they're great first-line drugs. HCTZ is typically the one they use, hydrochlorothiazide, works down in the distal tubule. The big question they always ask, it probably should be in red here. It causes it causes hypercalcemia, all right? So if you take a thiazide and then you check your blood, you'll have elevated calcium in your blood. It causes hypercalcemia, which is why it's good for treatment of hypercalciuria. If you have a lot of calcium in your urine and you want to pull it out of your urine and, you know, get it out of there, you can give a thiazide. So people that have chronic kidney stones, calcium kidney stones, you can give them a thiazide and it'll get all that calcium off out of their urine back into the blood. But thiazides are very classic, prototypical for something that causes hypercalcemia, okay? So make sure you know that. And just so you know, they work on these sodium chloride co-transporters down in the distal tubule. And I remember that they deal with calcium causing hypercalcemia, because remember PTH works down in the distal tubule too. So that kind of all puts it together for me. All right, so you can see the hypercalcemia. That's pretty much the big one you need to know there. Again, can cause hypokalemia, just like loops, right? Increase potassium excretion. All right, and that'll be different from the potassium sparing ones. Now, stuff like this, like I did highlight it, but honestly, like if you asked me in the exam if I knew that, I did not. Like, you know, it's one of those things. I don't go back after the test and change my highlighting, but things like that in numbers and stuff sometimes, you know, it's not terribly important. All right, so again, hypercalcemia, if it's not written on your slide, that would be the big one to know. And then, the mnemonic for this is GLUX. Let me just put it here for you guys. GLUC, GLUS. So it causes hyperglycemia, lipidemia, uricemia, hypercalcemia, and hypersensitivity. Okay, so what's important here? Watch this for diabetic patients. Okay, it's a good question to ask. Probably don't want to use it, right? Use something else. ACE inhibitors are good, right? They're renoprotective for those diabetic patients. Okay, so GLUX is the way to remember that one. All right. Now, potassium sparing. The way to remember these is it's SEAL. S-E-A-L, I believe. Yeah, so these first two are aldosterone receptor antagonists. What's very specific about these, they cause anti-androgenic effects. So they can cause like gynecomastia and stuff. Okay, but they're also potassium sparing. If you're not using aldosterone, that sodium potassium exchanger isn't going to work. So you're going to pee out a lot of sodium and you're going to hold on to that potassium. Okay, and then the other one, amiloride, what's the L for? Amiloride, hold on. I'm sorry, it's SEAT, not SEAL, it's SEAT. S-E-A-T, and triamterene is the other one. Okay, hold on, let me go back. All right, so just remember potassium sparing, the ones that work on aldosterone, they have anti-androgenic effects, okay? It's like gynecomastia. And then anytime you're messing with holding on to too much sodium, excuse me, or too much potassium, you're at risk for arrhythmias. Remember, that's a big problem, either hyper or hypokalemia. You have to watch out for arrhythmias. Very important, we'll get to in a little bit. You may not, it may not be intuitive, it's not to me, but spironolactone is one of those drugs that is, it helps to prevent cardiac remodeling, okay? So there are a couple of drugs, somebody could throw it in the chat if they want, but I think we're gonna come up to it. A couple of drug classes are prevent cardiac remodeling, which is very important because cardiac remodeling causes systolic and diastolic dysfunction, right? So by definition, these drugs such as ACE inhibitors, beta blockers, spironolactone, I believe maybe calcium channel blockers is the other one, they all prevent cardiac remodeling. So they all technically help with longer lifespan, right? Cardiac remodeling is the definition of heart failure, okay? So these drugs are very important, but it may not be intuitive that spironolactone is one of those, but it is. Okay, so things like digoxin is not, like, even though you think, well, it's helping contract the heart and work better, it's only for systemic, excuse me, for symptomatic relief. Okay, let's see, right. Yeah, anti-androgenic effects. Obviously hyperkalemia, right? Should be able to recognize that in the lab values. And then we have the ones that work on the ENaC channels, amiloride and triamterene. Not super important, but they're there. So again, they are potassium sparing. They're going to prevent that exchange from sodium and potassium. All right. And then carbonic anhydrase, acetazolamide, basically just helps to prevent bicarb. It's to prevent bicarb. You pee out bicarb, right? Is retained in the lumen. Yes. Okay. So it prevents reuptake of bicarbonate, right? So these are when you would want to use that. Mountain sickness makes sense because if you're in respiratory alkalosis from hyperventilating, you can use carbonic anhydrase. You'll pee out a lot of the bicarb and it'll acidify the blood and try to bring you back to baseline. Okay, so that's all you really need to know for that. Right, well, yeah. Yeah, so obviously if you're peeing out a lot of bicarb, you'll end up in metabolic acidosis. And crystal stones, yeah. Yeah, I don't know how important that is. All right, good. Again, I know I'm going kind of fast. If y'all have anything I want to bring up, just stop me. Osmotic diuresis. This will help, mannitol helps to bring all the water into the urine. It's an osmotic agent, so it'll bring a lot of fluid in so you could pee it out. Not really used. They probably want to ask you about that. Okay. ADH, this is not super important either, but ADH, right? Remember, brings free water back into the body. So if you have something like syndrome of inappropriate SIADH, of inappropriate ADH, you know, you can give something like this, right? There you go. And then you have your charts. If you're a chart person, go with that. All right, now anti-hypertensives, you know the staging by now. They could ask you that, but make sure, or pimp you in when you're doing small group with that. But this is what you should go with. Some textbooks or websites will give you differences. This is the standard that SGU uses, okay, for stage 1 and stage 2, or pre-hypertensive. Well, they don't even call it pre-hypertensive anymore. Just stage 1 and stage 2. All right. So again, with we're not going to go through how all this works. I want to just talk about the drugs. Right. So current treatments. All right. So again, if you're in heart failure, you want to decrease, you don't want to be in volume overload, you want to decrease the volume. So first line agents such as ACE inhibitors are going to be very important. You need to know which ones are first line, which ones are second line, and whatnot. Okay, so these all fall together. Remember, you never give an ACE inhibitor and an ARB together. They basically work the same. Okay, so you're going to give one of these two, throw a calcium channel blocker and a thiazide, you'll be good to go. You can also add a beta blocker and something like spironolactone too if you need to. All right, and then ACE inhibitors, I pretty much know how this works now. They're going to help to block aldosterone downstream, or it's going to block angiotensin 2, and angiotensin 2 will activate aldosterone and ADH. So if you use an ACE inhibitor to block angiotensin 2, you can help prevent the reuptake of fluid, and you can help prevent that vasoconstriction from angiotensin 2, right? So it's a twofold effect. Big thing with ACE inhibitors, they increase bradykinin. Bradykinin will cause a dry cough. It'll also cause angioedema. So if that happens, you just switch the patient. If the patient comes in with a dry cough, you switch the patient from an ACE inhibitor to an ARB. No big deal. Okay. You can see, y'all all know now how aldosterone works through this process. All right. Now, super important, it's very good for diabetic patients. ACE inhibitors, pretty much first line for everybody, unless you're in like severe renal failure. But definitely with these diabetic patients, you want to give them an ACE inhibitor. Okay, now, what actually happens when you give an ACE inhibitor is that it can cause dilation of the efferent arteriole, okay? So if our glomerular filtration is going to go this way, right? Blood's going this way, and it has two choices. It either goes down or it goes this way, okay? If we dilate this, right, like we're doing here, we're technically gonna decrease our GFR. GFR, okay? So ACE inhibitors will do this. ARBs will too. Because it's blocking this angiotensin 2, so you're not going to get constriction. So you can, now this is fine to a certain point, okay? So for people that don't have renal failure, decreasing your GFR a little bit is not that big of a deal, so you can use an ACE inhibitor. But when a patient gets into, say, stage 5 renal failure and their GFR is like 10%, you need to take them off of this because that 10% is all they have left, okay? But in a general sense, you can use ACE inhibitors unless there is a significant GFR reduction initially. Okay. Patients, right? So yeah, so like and I think Dr. Clunes brought this up a lot. This bilateral renal artery stenosis. If you were to give an ACE inhibitor, it will cause a drastic decrease in GFR. So you need to be aware of that. So not only those patients that have severe renal failure, but with this bilateral renal artery stenosis, adding an ACE inhibitor will decrease the GFR a lot quickly. So you need to be aware of that. So never give an ACE inhibitor if it's bilateral. All right, yeah, you can't give it in pregnancy either. You can get congenital malformations and decreased development, yeah, anuria and renal failure, okay? All right, good. Come on, oh, that's it. All right, so far so good. ARBs, very similarly, they just don't activate bradykinin, so you won't get that cough or the angioedema. And they end in sartan. All right, so same mechanism pretty much. Don't give them in pregnancy, same principle as ACE inhibitors. And again, with that bilateral renal artery stenosis, it is the drug of choice for unilateral. So make sure they're talking about bilateral. Too much decrease in GFR too quickly, not good. All right, and then renin inhibitor, you think they like this drug. I don't know what the pharmacokinetics of it, but they don't use it that much. I just remember it's a renin inhibitor because it ends in ren. Okay, but I doubt they'll ask you about this one. Okay, so then we get to our calcium channel blockers. Now, there are two classes. They're the non-dihydropyridines and the dihydropyridines. it is important to note the differences here. Dihydropyridines basically only work on the vasculature, okay? They're gonna work to vasodilate the vasculature. The non-dihydropyridines work on the cardiac myocytes and the vasculature, okay? So typically, if a patient just has benign hypertension and no heart failure, you just give them one of these and you just dilate their vessels. But if a patient does have some sort of heart failure and hypertension, you give them the non-dihydropyridines. I always got these confused. It was a pain. So I just remember DNA. So DNA, right? DNA, those go together. And those are just for the vasculature. That's what we're talking about here. The other ones go with the other set. All right. Good. So you know that they also fall in that class class 4 of the antiarrhythmics, or calcium too, right? So those are when you're going to use those non-dihydropyridines. All right. Kind of just goes into the process, but it's the sodium calcium exchanger. So you're blocking calcium from being available to the myocytes. All right, so again, first line drug. And just take note, you would not give these dihydropyridines for cardiac arrhythmias. If you think about it, these are just working on the vessels. So if you vasodilate the vessels, you can get reflex tachycardia. It may precipitate some sort of arrhythmia. So just be careful with that. You'd want to give one of the non-dihydropyridines because it's actually working on those cardiac myocytes too. Yeah, here you go, that reflex cardiac stimulation. Big one, I put it in red. They like to test on that. Verapamil will cause constipation. Gingival hyperplasia as well. Now, the non-dihydropyridines, these are the ones that would fall in that class 4 that you'd want to give for certain arrhythmias. And then we're not going to talk about the diuretics again, but yeah, so again, the glutes is what you can use for that, for these thiazide adverse effects. Loops, we talked about those, potassium sparing. Was there a specific slide that said which ones are prevent myocardial remodeling? Maybe not. And then beta blockers, of course, these are basically just going to help to slow down. It's more of a beta-1 effect. You're slowing the heart rate down because if you think beta-2, well, you're preventing that vasodilation. You think of these as more of the beta-1 effect that they use, right? So you're thinking of like a atenolol and metoprolol. Remember A through M, the ones that fall A through M are selective. So they'll choose like beta-1 over beta-2 and N through Z, beta-1 equals beta-2, okay? So it's a little tricky. Why would you want to block beta-2 since it does vasodilation? But this is mostly, think about the beta-1. You're putting some relief on the heart from working so hard. Okay, and you can see this here. All right, the thing that they like to talk about with beta blockers is that in diabetic patients, when they have episodes of hypoglycemia, a lot of times the first symptom of that is tachycardia, okay? So if a patient's on a beta blocker, a diabetic patient is on a beta blocker, they need to be aware that they might not get that initial warning sign of tachycardia because the beta blocker is in essence slowing down the heart rate, okay? So that's a good test question. Obviously, you're not giving a beta blocker to someone who has asthma. All right, so alpha-1 blockers, remember alpha-1 works on those vessels to vasoconstrict. If you block those, you can vasodilate, right? So that's good. Also, they use it for BPH as well. Okay, so yeah, you're blocking that sympathetic response so you can, the patient can urinate better. All right, and then Mixed alpha beta, yeah, these are more common these days because you could get you can block that alpha 1 and you could also block the beta 1 of the heart. So you get vasodilation and you get a decreased heart rate. Clonidine is a tricky one because alpha 2 is more of an inhibitory, it's centrally acting. So it has this like autonomic effect of inhibiting the autonomic system. So it like slows down your sympathetics. They use that sometimes. The thing you have to watch out for this is if patients get off of this too quickly, they get what's called rebound hypertension. So their blood pressure skyrockets. Okay, so if you ever see rebound hypertension, they're talking about clonidine. It's classic for that. Here you go. Methyl-dopa, good for pregnancy. That's the drug of choice there. So keep that in mind. And then you have your direct vasodilators, okay? So hydralazine and minoxidil, which is Rogaine, actually causes hypertrichosis. They don't use it first line, but it works directly on the smooth muscles to dilate the vessels, okay? On the arterioles, direct vasodilators. All right. Watch out for that lupus-like syndrome. They'll just give you symptoms of lupus. They won't tell you it's lupus-like syndrome. So you need to know the drugs that go with that. And if there's any sort of malignant hypertension that you need to address immediately, minoxidil can work. But typically they talk about hydralazine. All right. Pulmonary hypertension. Remember, anytime you have pulmonary hypertension, it can lead to cor pulmonale, which means right heart failure. So you don't want that to occur. So prostaglandins are always going to help to vasodilate. So that's a good way of doing it. Endothelin is a vasoconstrictor. So if you inhibit that, you could be good. Sildenafil is Viagra, but it is a vasodilator. So it can be used in pulmonary hypertension. Okay. And you can see it is important that you know which they go with which. So ibuprostol is PGI2. I think that's really the only one you need to know. Bencentin, I don't know if they'd ask you about that. And they just like this one, the class that it works, right? So it's inhibitor of phosphodiesterase 5, increases CGMP, increases nitric oxide. So it'll improve blood flow, as Viagra or in the pulmonary system. Can't give it to a patient on nitric oxide. A lot of patients take nitro for angina. They take those sublingual tablets, nitroglycerin, and it'll help to vasodilate the coronary vessels, right? But so you can't give them something like this because that's too much nitric oxide. They'll vasodilate too much. They'll go into shock. All right, so definitely know these. These are very important, what comes with what, first lines versus second lines and stuff like that. And just knowing importantly, like diabetes, definitely get them on an ACE inhibitor that's renoprotective, stuff like that. All right, good. All right, then we get into the hypertensive crisis. So again, nitroprusside is a good one that you can use. That's typically what they use. This is the emergency situation. So you need to get prompt vasodilation. These patients coming in, their systolic pressures over like 200. Okay, it inhibits, I think, complex 4 of the electron transport chain. So it causes cyanide toxicity. You can give sodium thiosulfate to treat that. Yeah, not that that's high yield, that you'll get to that later. We talked about labetalol. I'm pretty sure labetalol is good for pregnancy as well. It doesn't say that here, but I'm pretty sure that's right. Vindolapam, whenever you think of a dopamine receptor agonist, think that it's good for the kidneys, okay? Typically, the only thing I've ever seen when they use something like this is when they're worried about the kidneys, such as renal insufficiency, okay? Because they have dopamine receptors, I believe, in the afferent arteriole that help to vasodilate, so you get increased blood flow to the kidneys. So that's good to know. Yeah, calcium channel blocker, of course, nitroglycerin. Yeah, but typically they would give nitroprusside. All right. Yeah, and then these are just, you can go through these on your own. Hydralazine is good for pregnancy as well. So anytime patient gets eclampsia or preeclampsia, you know that causes hypertension, you can give them hydralazine. All right, heart failure. Now we talked about this, what the difference is, systolic versus diastolic. So systolic, you should say pump failure. If you're giving drugs to help with pump failure, you're going to give something that's going to help the pump work better. If you remember, diastolic is talking about filling problems. So if you're giving something to help with the filling problem, you're giving something to help relax the heart. Now, there are some crossovers here that you want to give just in heart failure in general, but some of the specific ones, such as digoxin, right? You give it for systolic because it helps the heart pump better. Whereas for diastolic, you can give like a calcium channel blocker. It'll help relax the heart and help it fill better. Okay, so keep those in mind. You know, if you think about it, think through it, you really don't have to memorize it. It'll just make sense. Okay. Yeah. Okay. Right. So reduced ejection fraction. We're talking about an ejection problem. Okay. So it's dilated, it's floppy, and there's an ejection problem at this point. So spironolactone, direct vasodilators, those can be used, inotropic agents such as digoxin. Whereas diuretics, the ones in yellow, you can use for either reduced or preserved. Okay, so ACE inhibitors, diuretics, beta blockers, give them for all. I think spironolactone may as well be for both, but direct vasodilators and inotropic agents you want to give for reduced because it'll help the blood flow, help the pump work better. Okay, so don't listen to me. Spironolactone apparently is only used in reduced ejection fraction. Okay, that's why it's in green. But if it's preserved, I guess you don't want to use that. Again, so preserved, we're saying that it's a diastolic problem. We want to be able to relax the heart a little bit more so that we can get more blood into it, right? So again, you could use diuretics, ACEs, beta blockers, and the one that you would want to use in preserved ejection fraction is calcium channel blockers, because again, that calcium blockade will help to relax the heart a little bit more. It'll help to feel better. All right, good classes, that's fine. Yeah, so here's the example of prolonging survival. They help to prevent myocardial remodeling. So by definition, you're helping with survival. Of course, they are teratogenic, so be careful with that. Same thing with the ARBs. Direct vasodilators, talked about those. Here's one of those things that comes up sometimes. For whatever reason, ACE inhibitors don't work as well in African-American populations. So you can switch them. Instead of using the ACE inhibitor, you can use a direct vasodilator. Okay, just in case they ask you that on the exam. I don't know how clinically, if doctors even go through that process, but I think there were some exam questions that talked about that. Okay, again, remember direct vasodilators work on with nitric oxide. You got to watch out if the patient is on sildenafil. And then again, hydralazine, that lupus-like syndrome that comes up. All right, beta blockers, reverse cardiac remodeling, help with long-term survival. Okay, now this should make sense. If the heart can't properly compensate, right? If it can't compensate for the heart failure. So say the left heart's failing and the right heart has to get more blood to if it can't properly do that to keep the stroke volume up, you don't want to give a beta blocker, because the beta blocker is going to stop or decrease the blood flow. It's going to decrease the work of the heart. It's going to decrease contraction. So if you're decompensated, your heart's working just to keep you alive. So giving a beta blocker is not exactly a good idea. Okay, and we talked about spironolactone. Yeah, with those, remember they have those anti-androgenic effects. Hyperkalemia, watch out for arrhythmias. Okay, now digoxin's the big one. Again, they really don't use it that much anymore, but when it first came out, it was like this novel drug, you know, it like makes the heart just work better. Remember, it has this inotropic agent. It's a negative chronotrope, which it means it slows down the heart rate, but it's a positive inotrope, which makes it squeezes better, right? It contracts harder. And it works. Yeah, you see that here. Right, and yeah, so by doing that, working together to have more of a less heart contraction, but when it does contract, it contracts stronger. That process will help to decrease myocardial oxygen demand, okay? And this is how it works. Basically, it blocks the sodium potassium ATPase. So sodium will be inside the cell. This is tricky. This is bidirectional, these little arrows. So what happens is by blocking this, there's a ton of sodium in the cell. So the sodium over here wants to rush out of the cell. So it rushes out. That means calcium comes into the cell. So there's a lot of free calcium, okay? They could ask you about this process. So just remember, this goes both ways. So if you have a lot of sodium in, you kick the sodium out to bring calcium in. The more calcium you have, the stronger you can contract the heart, okay? Yeah, so atrial fibrillation. So the atria is just kind of shaken, right? You need to be able to say, slow down, let's have a nice concentric heartbeat, right? So atrial fibrillation is a good example where digoxin could be used. But again, digoxin is for symptomatic relief. It's not gonna help with cardiac remodeling or anything like that. And this is why it's really not used as much anymore, because of this toxicity, okay? That it could have. One of the ones that they talk about classically is this yellow hue in your vision. So be aware of that. Anytime they talk about that, or halos and dark objects, that could be digoxin toxicity. Now, these precipitating factors, what this means is if any of this is happening, when you give digoxin, it could lead to digoxin toxicity, okay? So if a patient has hypokalemia, that will block this pump, which means there'll be more sodium available to help to shuttle the calcium. So it can cause too much calcium intracellularly. But just in case these come up, it's a little complicated, but just be aware of these. These can lead to, if the patient is in a setting of this and they take digoxin, it could cause digoxin toxicity, okay? And these are the interactions. So whereas if you have hypercalcemia, it could lead to digoxin toxicity, or hypomagnesemia, they work opposite, okay? So just in case they ask that, I don't know if y'all have come across questions like that. That is a little bit complicated, like I said, but those are some of the things. But the main one to remember is a setting of, you never want to give digoxin in the setting of hypokalemia, okay? Because that'll make it worse. All right, then the adverse effects as well. Okay. Right, and so you never want to give it for a diastolic dysfunction. You always give it for systolic because it will help with contraction. All right. Treatment for diet, okay, we kind of talked about this. Here are some other inotropic agents. Go through these on your own. I mean, these weren't super important. CAMP, phosphodiesterase inhibitors, yeah, okay. I don't know that they'll ask about that. Remember when we talked about dopamine, we're talking about help with renal perfusion. Dobutamine, they only give this when the patient comes in and they're in complete heart failure, and it'll help to stimulate the heart, stimulate contraction. Glucagon can be used, increase CAMP, so similarly to like beta agonists as well, right? Works through a similar process. All right, now, again, like I said earlier, these antiarrhythmics are difficult, but the test questions weren't as bad as I thought. Like they only tested us basically on what I'm going to explain to you guys here. So there are two different electrical impulse graphs that we're going to look at. This is the myocardial, the one you know classically, right? So we have that upstroke of sodium, then the potassium, then that calcium plateau, and then potassium, and then sodium, right? So the class 1 and class 3 are going to work on this graph, okay? Class 2 and class 4 are going to work on the actual nodes, the SA node specifically, okay? So when we look at these, I mean, we've talked about this in FTM and stuff. I want to get to the drugs. So as I said, you can see the two different graphs. Remember, 1 and 3, the sodium and potassium antiarrhythmics are going to work on this. And then 2 and 4, the beta blockers and calcium channel blockers are going to work on this, okay, the pacemaker graph. So it's very, very different and very important that you know the differences there. Okay, let's get to the drugs. So again, they briefly talk about these different arrhythmias, but we really get into it in term 5. You really don't need to know how these work right now. You just need to know the definition of how these drugs work. Okay, so the class 1, remember, so it's sodium, so we're gonna work on the myocardium. Okay, so 1A, B, and yeah, let's get to those. Okay, so the sodium. So we're working on the myocardial graph. Did they not show it again? Okay, here we go. Yeah, so you want to slow the rate of the phase 0 depolarization. And what you could do is you could see that here. So on a test question, they could ask you, they could say the patient has an arrhythmia. They want to use a drug that will not only extend QRS, but it'll also extend QT. Okay, so you would know the definition. That would be a good example of a class 1 antiarrhythmic. They may even give you this graph, okay? We had graphs like this. So make sure you're able to identify this graph and know which one goes with which, okay? Right, and there are some weird little side effects, like quinidine has this synchronism, blurry vision, tinnitus, and headache, even psychosis. So be aware with that. Another good thing that you could know now, anything that increases QT, okay, can lead to torsades de points. Now, why is that? If you extend, let's go back to the picture. If you extend this QT right here, what you're doing, like the longer, so by extending QT here, you're making this, technically you're making this whole interval longer. I mean, you're extending it here. But what happens in this zone is very dangerous. You're tempting fate here, because what can actually happen is you can get re-entrance. You can get abnormal polarizations here. And the problem is the longer you prolong that QT, the more opportunity they have for an aberrant impulse to go through. Okay, so just keep in mind, anytime you prolong that QT, you can be at risk for getting torsades de points, which means it starts firing straight through. And so it's big for the class 3 drugs, but it can happen in these as well. Okay. Canamide's another one. Again, lupus-like syndrome. Good to know that. This is the other one, dysopyramine. I don't know that they asked us anything about that. Just know which drugs go with which class. Okay, good. Let's see. Okay, so now they could ask you, we want to use a drug that prolongs QRS but shortens QT. That's classic for these 1B antiarrhythmics, such as lidocaine, okay? So again, you have to be a cardiologist looking at arrhythmias to decide, do we want to shorten the QT or prolong the QT or whatever? So you don't really need to be able to differentiate types of arrhythmias with the drug. You want to just be able to identify what goes with what by definition. All right, but a caveat, it is good to know that lidocaine can be used for ventricular arrhythmias. Okay, so just know that too. It comes up in term 5 as well, but just keep that in mind. Okay, so then we have our class 1C. Now look at this. What if they said we want a drug that will prolong the QRS significantly, but not change the QT? Well, then you could use the 1C drugs. Okay. So again, ventricular arrhythmias, but again, this could be used for either. So, you know, take that as with a grain of salt. This is a great example of something they could ask on the exam. I would put a star on this slide. So make sure you can differentiate these different graphs, which one's 1A, which one's 1B, and which one's 1C. All right, definitely high yield. Okay, phase 0 and 3, phase 0 and 4, and just phase 0 here. Okay. All right, and then our beta blockers. Now, we said this class 2, these beta blockers are going to work on the node. Okay, so we're looking at that nodal graph now, the SA node. So what they do by definition, they decrease the slope of this phase 4. Those initial phase 4 sodium funny channels. If you decrease the slope, it's going to fire less frequently. Okay, so you're going to get a prolonged or increased PR interval. Okay, and that'll help to slow down those SA nodes the SA node firing. All right, and then it just kind of goes into, you know, the side effects of these beta blockers. All right, now potassium channel blockers, class 3. We're going back to the myocardial graph. Okay, now look at this. Look what they do. They prolong this QT. That is what they do. They work on this repolarization phase, this phase 3 potassium channels. So what do you think is a big problem here? Torsades points, right? Or having these new arrhythmias that form. Okay, so you have to be aware of that. Amiodarone is very tricky. I'm not sure that they use it so much just because it has so many side effects. Okay, so you can see here, like, it could be used in the atrial arrhythmias or ventricular arrhythmias. So it's not going to be important that you can differentiate what arrhythmia to use this with. You just want to be able to classify it, okay? So it's by definition going to prolong this QT phase. It's going to work on phase 3, this repolarization phase, by blocking the potassium channels. All right, and then here are some of the side effects here. Pulmonary fibrosis, that's a problem, right? It could cause hyper or hypothyroidism, get photosensitivity. Another thing, a big buzzword, blue skin discoloration. And then again, of course, it could cause torsades de points. All right, sotalol falls into the same category here as that class 3, and dofetilide too. Okay, atrial, let's use it primarily for atrial issues. All right, then class 4, now we're jumping back to the nodal graph, okay? So these calcium channel blockers, similarly to the beta blockers, will increase your PR interval. So we're slowing down the heart rate. Now, these will work on the calcium aspect. Remember this phase 4, and then this is phase 3. Excuse me, wait. Sorry, this is phase 4. This upstroke is the calcium phase, which is phase 0. So it's going to slow the rise of this portion of the action potential. Remember, the beta blockers worked on 4 over here, which was this sodium funny portion. Sodium funny portion. The sodium funny channels. The beta blockers work down here on this portion, phase 4. They slowed the slope. They decreased the slope. Okay, that was the beta blockers. And now we're looking at this. This is called phase 0. This is the calcium phase. So if they slow this rise, these class 4s, then it'll help to increase your PR interval, so it can help to prevent tachycardia or arrhythmias. Okay, remember, we're using those non-dihydropyridines because they work on the heart as well as the vessels. Okay. And then you can see the atrial supraventriculars. Again, don't forget verapamil causes constipation. And then digoxin, we talked about that, positive inotrope, right? Negative chronotrope. Typically, okay. Yeah, so they'll use it to control ventricular rate if they did use digoxin. So a flutter or fibrillation. But again, like I said, y'all really, if y'all just know the definitions, what does what and works on what phase of those graphs, you're golden. Adenosine, yeah, very short acting, can help to fix arrhythmia short term. Right. So abolishing acute supraventricular tachycardia. So you can give adenosine, and it'll help to fix it in an acute setting. And I don't think they'll ask you about any of this, magnesium, atropine, anything like that. All right, what's left? I think they just go over, okay. They kind and like, just know, okay, this should make sense that the ones that work on those nodal graphs are beta blockers and calcium channel blockers, right? Those were the graphs. The ones that worked on the muscle were the sodium and potassium. So 2 and 4, beta and calcium work on the nodes. 1 and 3, sodium and potassium work on the myocytes, okay? Other than that, like diving into this too much, just not, you don't really need to. All right. Yeah. So it should make sense. If you want to slow the rate down, you can give these beta blockers, calcium channel blockers. That should make sense. And then rhythm control can be done with these. Again, this is a little bit more than you really need to get into. All right. So anytime you have an angina, you can give nitrates. That's pretty much first line. It will help to vasodilate, help with that chest pain. Beta blockers will slow down the heart. Calcium channel blockers help to relax the heart. Ranolazine, it almost works opposite of digoxin in that it prevents intracellular calcium. Okay, so if you don't have intracellular calcium, the heart won't work as hard. It won't have as strong of contractions. All right, but you know how these work. Nitrates, nitric oxide goes through the cGMP pathway, guanylyl cyclase. All right, and much of the same here. Right, so if you keep in mind that in the beginning of the lectures, this lecture, which ones to use with angina, you want to slow down the work of the heart, oxygen demand, and you want to vasodilate. So think about that, and that'll help with the angina. First line is typically nitro. All right. All right, coagulation. This is a great, I don't know that I'm even going to go through this. I think Dr. Dasso does a really good job explaining everything here with these. Know just what classes go with what, and you know what the major side effects are, right? But I think Dr. Dasso's test questions are very similar to his IMCQ questions. So just know what goes with what. Particularly know about heparin and warfarin, right? Remember, warfarin takes a little while to kick in, a couple of weeks, so you always give heparin first as you transition to warfarin. Know like heparin-induced thrombocytopenia, that's a big problem with heparin, and know that the side effects of warfarin too, in regards to like vitamin K. If you have too much warfarin, you can give vitamin K to help to alleviate it. All right, and then the hyperlipidemics, I mean, knowing, oh gosh, yeah. There were like hand signs for this, right? I forget them. Like 1 is chylomicron, 2 is LDL, something like that. I'm sure somebody has the picture. I might have used it in one of our old reviews. All right, so first line statin always, unless there's a reason not to give it. but knowing which ones directly do what, like statins, the big thing about statins is they decrease LDL. Like some of the other ones, I don't remember off the top of my head, but like fibrates will decrease triglycerides. Like that's a big thing. So knowing what their major effect is will be important. Niacin, remember that'll cause flushing. You can give aspirin prophylactically for that, but knowing stuff like hepatotoxicity and hypoglycemia as well, knowing that, yeah, LDL, yeah, there should be a table somewhere that has everything. Honestly, I might get 2 or 3 questions on this, so. Yeah, but yeah, so like, see what I have highlighted here? Statins work primarily on LDL. Fibrates are gonna work mostly on triglycerides. Niacin is gonna help with increasing your HDL and decreasing your triglycerides, okay? So these are kind of things that are important to know. Yeah, and here you go. So this would be what would be good. If in doubt, just give a statin, except they're contraindicated in pregnancy. All right, and I'm not going to go through this one either. I don't know why this was thrown in here, but yeah, these different things, right? So you've come across some of these already, TPMT, but these are just modified genetic, different genetics that lead to certain issues with medication. So for the sake of time, I'm not going to go through all this, but I think that's all for that. Maybe I'll do the infection one real quick. And then Lindsey can go through. Should we take a break? Yes, okay, just a couple minute break. I'll do this and Lindsey will finish the renal portion. All right. All right. We'll quickly go through these UTIs. Remember, UTIs in themselves, problematic, yes, but the real problem comes in when the infection regurgitates up from the bladder into the kidneys, right? Up through the ureters into the kidneys. That's when you get really bad problems. So when we talk about lower UTIs, we're talking about cystitis, but that pyelonephritis is what you really want to watch out for. So Staph aureus, big problem. Typically, females have a shorter urethra, so they have a higher prevalence of UTIs than males. But what you'll see is Staph aureus is there. Some of those Enterobacteriaceae classes, this Staph saprophyticus and Enterococcus species, they can cause it as well. But think about these when you do think about it, these gram-negative rods. E. coli, Klebsiella. Proteus is big. When you think about Proteus, you need to think about stone formation. So these are all going to form urease. And anything that forms urease is going to make stones. But when they give you this situation, Proteus is the big one. It makes those huge staghorn stones, okay? All right. So we can get into, yeah, so and it can lead these lower UTIs can lead up to pyelonephritis. Typically, they'll talk about costovertebral tenderness, and it can even lead to things such as papillary necrosis, which is like sloughing off of the papilla or the of the tubules. And you can see that here, some other complications of papillary necrosis. So if they talk about diabetes, urinary tract problems, sickle cell disease is another one, and prolonged NSAID use as well. So a lot of times they'll give you this. The one they like is they'll say somebody recently had a back problem. They've been taking, some sort of NSAID, ibuprofen every 6 hours for 2 months. They ended up with papillary necrosis. Okay, so be aware of that. Right, and right. So cystitis, frequency, urgency, burning, pyelonephritis, much worse symptoms, right? You get fever, costovertebral angle tenderness as well. Okay. Y'all have talked about this, and Lindsey's going to go through it. Post-streptococcal glomerulonephritis. They always have to preface it with they had a previous strep infection, right? Typically, this happens in kids. They usually get better right away. And again, it shows that molecular mimicry, similar to like in rheumatic fever. Okay, so you can see that here. Right. And then lower UTIs, cystitis. So lactobacillus, they are common in the vaginal canal. So they help to acidify the vagina to help with infections. Right, and this reflux, this vesico-ureteral reflux is what you're worried about when that cystitis goes into pyelonephritis. Right, but primarily when you're thinking, if they don't give you any other information, E. coli is going to be your first thought for cystitis. Catheter associated, again, E. coli, Klebsiella proteus. Those are common on the skin flora, so they're going to come up. Yeah, acute hemorrhagic cystitis can be caused by adenovirus. Yeah, not terribly important. No, the specific strain of E. coli has those standard features, those virulence factors here, lipid A. All right. Proteus, remember, like I mentioned with Proteus, you're going to get those staghorn stones. So that's a problem. They're actually magnesium ammonium phosphate or striuvate stones and calcium phosphate. Okay, so it's a big problem. You see the urease production is through the roof, and that's what's going to end up causing those stones. Staph saprophyticus, if you remember that this correlates to honeymoon cystitis, then you'll get it right. It has a right. So when they talk about this, they say people were on their honeymoon or sexually active, and it just happened recently. So you could see that they'll have negative nitrite because they are gram positive. Okay, so anything that is nitrite is gram negative. If nitrite comes up positive, it's a gram negative. So Staph saprophyticus is gram positive, so it's going to have a negative nitrite. Whereas all the other stuff, pretty much all the other stuff we were talking about, except Staph aureus, is gram negative. But you can see urease production, so you can get stones. All right, and this kind of breaks it down, but y'all can look at this on your own. All right. Yeah, so, again, right, this is what you would expect. Suprapubic tenderness, cystitis, costovertebral angle tenderness, think pyelo. All right. It's all yeah, okay. Well, yeah, definitely check this out. Leukocyte esterase, that would be positive in the presence of neutrophils. All right, so that could be indicative that there's an infection there. Nitrite test is going to test to see if there's any gram negatives there, which there might be. Anything that makes urease is prone to making stones. The big one's Proteus. All right, good. Culture it, yes, good. Here's a nice little picture. E. coli is urease negative, but nitrite, right? So anything that's gram negative, all three of these will have nitrite. Anything that's prone to making stones will have urease. Wait, did I say leukocyte esterase was, I might have said leukocyte esterase was presence of neutrophils. I think that maybe that's secondary. Maybe that's secondary to the infection, sorry. So these all actually are gonna have leukocyte esterase. I think that actually means that neutrophils would show up, but don't quote me on that. I mean, it would make sense because they're a bacterial infection. Anyway, okay, so yeah, so good here. If you have this memorized, you should be good with all the the cystitis infections, Proteus, staghorn stones. All right, good. Good. I am done. Lindsey, you want to knock out this pathology real quick?
Yeah, let's finish this up real quick. So since we're, I already talked about this, I'm not going to go into it again, but just understand nephrotic versus nephritic. So again, just pulled out the big things you need to know on here. You know which are nephrotic versus nephritic because you can tell what kind of pathology it's going to be based off of the lab. So nephrotic, high proteinuria. Minimal change disease, you're looking for a kid with a history of a respiratory infection, or if they were recently immunized to prophylactic immunization. So nephrotic, so you're going to have proteinuria greater than 3.5 grams. No hypertension, remember hypertension is more associated with nephritics. And then anasarca, which is generalized body edema, which makes sense because if we have a high proteinuria, then we don't have any protein, we don't have a lot of protein in the serum. And so you're getting a lot of fluid leaking out into the interstitium. So the three big things about the glomerular diseases are light microscopy, immunofluorescence, and electron microscope. Those are the three things that are going to be indicative of each individual. One, because sometimes they don't give you like a clear-cut presentation of this is this, this is this, this is this. So normal glomeruli, they will most likely tell you that there is normal glomeruli, or they'll describe a kid with minimal change disease, and then normal glomeruli will be a characteristic of it. No immunocomplement deposition, and then the big thing is that there's effacement or fusion of the foot processes of the podocytes. Remember, nephrotic, you get damage to the podocytes, which is why you're getting all the protein out in the urine. And then something that I remember being important, this does respond well to corticosteroids, versus the next one, focal segmental glomerulosclerosis, which does not respond well to corticosteroids. So this one is more associated with HIV and obesity, chronic reflex nephropathy, heroin use malignancies. Light microscopy, getting the segmental sclerosis and hyalinosis, kind of goes along with the name focal segmental glomerulosclerosis. Glomerulosclerosis. Immunofluorescence that can either be negative or non-specific granular deposits of IgM, sorry guys, and C3 complement 3. EM, again, like minimal change, you have diffuse effacement of the foot processes. And then these do not respond to corticosteroids. And then many of them are going to progress to chronic kidney disease and even end stage renal disease. Once you get to ESRD, you are put on dialysis and it's end stage. And so your kidneys are not functioning, or your kidney or kidneys plural are not functioning at that point. Notable, the proteinuria in focal segmental is insidious. So you're not going to have symptoms initially. It's going to be later. And then it's non-selective. The proteinuria is non-selective, so you can get all types of protein. Nephrotic range, of course. And then the degree of proteinuria is going to be your prognostic indicator. Remember, this can have a really bad prognosis. It's not going to respond to corticosteroids, and then you can develop ESRD. And so the amount of proteinuria, if you're not catching it early, can be your prognostic indicator. Membranous nephropathy, again, nephrotic. So males 2 times more likely than females, more likely in the elderly. So these are going to be more, this is autoimmune. So look for the PLA2R. So against those on the podocytes. And then this is what's going to lead to the immunocomplement, immune complex deposition. So this is associated with lupus, malignancies, drugs, and infections. The biggest thing are the spike and dome appearance that you can see on light microscopy and electron microscopy. And then the deposits, you need pay attention. It says granular, so versus linear, granular IgG and C3 around the glomerular basement membrane. That's also very important because some are going to deposit in different places. So when you get to these glomerular diseases, a lot of the times what's going to differentiate are just these characteristics right now. Again, poor prognosis, you're going to have a large amount of proteinuria per day. So kind of makes sense if you're in a nephrotic syndrome and you're getting all of this protein out in the urine, it makes sense that your prognostic factor would be the amount of protein in your urine because it's kind of a measure of how much podocyte damage you have. And then renal amyloidosis, they give you two types, primary and secondary. Know what type of amyloid you're talking about and what's associated with. So AL is with multiple myeloma, AA is with rheumatoid arthritis. Big things here, you're gonna have Congo red stain and then apple green birefringence, and then presence of apple green birefringence. Electron microscope with non-branching continuous fibrils, and then clinical features up at the top. This is going to be how you can detect it in your vignette. Okay, now we're moving on to nephritic. So you're still getting the proteinuria, but it's going to be less than 3.5 grams. But this clinical presentation is going to be associated with hematuria, so bloody urine. People are coming in, they're peeing blood, and this is inflammation to the glomerulus that is leading to this. So IgA nephropathy or Berger's. This is all mesangial, so no matter if you're looking at light microscopy, immunofluorescence, or electron microscopy, it's all deposits in the mesangium. So get proliferation, deposits of IgA with C3, and then of course mesangium, again, deposits there. What are you looking for in your clinical vignette? A kid coming in with episodes of peeing blood. So it's episodic, so you will, they will have a peeing episode of blood, then not. If they can't see the blood, most likely you are getting microscopic blood, so it's not like it's going away, you just can't see it. But you have normal serum C3, C4. This is really important because when we talk about some other nephritic diseases, you don't have normal serum complement. And so highlight that. That's going to be something that will clue you in on this in your clinical vignette. So kid, episodic hematuria, normal serum complement. And then this can progress to ESRD. There are some associations, arthritis, vasculitis, non-thrombocytopenic purpura. I'm not going to try to pronounce that, HSP. And then they loved to, it's associated with celiac disease. So that's a common one. So, gluten intolerance there. Post-streptococcal glomerulonephritis, hopefully this will be very easy to identify because it's going to be a kid who had a strep throat or a skin infection. So now they're going to be presenting with edema. Then tea or cola colored urine, they might put that in the vignette. So kid, strep throat, now has like tea colored urine, will be hypertensive. Remember, nephritic syndromes, they commonly are hypertensive because you are increasing renin because of what's going on in the pathogenesis. So increase of renin, you're going to have retention and you are going to get your hypertension. So the kid will be hypertensive. Light microscopy, it's going to be hypercellular glomeruli, immunofluorescence, granular deposits of IgG, IgM, and C3 along the glomerular basement membrane. Remember those three, where they are. And then subepithelium humps, that's a big thing. And then to diagnose, they might either say that there are the titers in the vignette, or they'll ask you, how can you diagnose it? Because at this time, you don't have the bacteria anymore. Membranoproliferative, there are two types, type 1 and type 2. They will both present with hypocomplementemia because you are using up complement in their serum, so you're not going to have it. So They are both type 1 is associated with the classical pathway. It's going to be IgG complement mediated, associated with hepatitis. And then both of them, you're going to have the tram track appearance of splitting of the glomerular basement membrane. But notice between type 1 and type 2, type 1, because it's IgG mediated, you're going to see IgG deposits on immunofluorescence, whereas type 2, it's not IgG mediated. So you're not going to see IgG. So you'll both still have C3, C1q, and C4, but the difference is going to be IgG in the immunofluorescence deposits. So T2, alternate pathway, circulating C3 nephritic factor, which leads to C3 activation. So if you're constantly activating C3, constantly activating the complement pathway, then you're not going to have complement in your blood. That's why you have hypocomplementemia. Okay, so clinical features, what are you going to see in your vignette? So hematuria or proteinuria on a UA, acute nephritic syndrome, of course, we're talking about nephritic. So hematuria, which is, a hallmark of nephritic syndrome, hypertension, which is also a hallmark of nephritic syndrome. And then you'll have some edema, recurrent episodes of gross hematuria. All that gross hematuria, all that means is you can see it versus microscopic. And then insidious onset of edema and nephrotic syndrome. So you don't just have maybe one or the other. Some of these can progress. And so this can progress to edema and nephrotic syndrome. And then rapidly progressive glomerular. This is a rapid and progressive loss of renal function, but this is the endpoint of like other etiologies. It's not that this just stands alone. You have something else, and then you get to a point and you have rapid and progressive loss of this renal function. And so progresses to death if left untreated. So histology, the glomerular damage is so severe. Remember, it's kind of like an end stage. Fibrinogen leaks out into the Bowman space, and then you get proliferation of epithelium, and that is what's forming the crescent, which is in the histo slide right there. Type 1, type 2, type 3. When you hear the word Goodpasture syndrome, I hope you immediately think of anti-GBM antibody mediated reaction. Those two terms need to go together in your head. Also, linear immunofluorescence. Up until this point, we've only talked about granular, but Goodpasture syndrome is linear immunofluorescence. And then it's a type 2 hypersensitivity reaction. Type 2 immune complex mediated. So this is more going to be your post-infectious, your IgA, your HSP. So this is all granular immunofluorescence. Type 2, essentially just know that those can develop into rapidly progressive glomerulonephritis. And then your type 3 or ANCA mediated, we've talked about those in the vasculitides. So this is coming full circle, because all of those vasculitides, the small vessel vasculitides, had presentations in the kidneys, because you're talking about the vasculature there. So Wegener's, microscopic polyangiitis, Church-Strauss, these have no immunofluorescence. But they are ANCA mediated. So that's very high yield, very important. Remember the different ANCAs that are associated with all the different small cell vasculitides. Clinical features, I put this in here really for completion's sake. You can look over that. Okay, lupus nephritis. The kidneys, you've heard about lupus, autoimmune disease affecting multiple organs. The kidney is just one of those organs. So, there are so many things that can present from this disease, but we're just talking about the kidneys right now. I made a point to point out the ANA and double-stranded DNA. These are serum markers that you are going to be able to look for to say, yes, this is lupus nephritis. A person comes in with kidney stuff. You don't know why they're having kidney stuff. This confirms that it's due to lupus. So other things, just look for symptoms of lupus. So fever, leukopenia, thrombocytopenia, all of these things. SZ is seizure. But just look for a presentation of lupus. And then when we're talking about renal presentation, if you come in and you're presenting with renal issues, this can confirm that this is lupus nephritis. And then on immunofluorescence, everything is there. So it's positive for absolutely everything. The classes here is basically just staging of what you can see. So, I mean, you can minimal mesangial, mesangial-proliferative focal nephritis. So it really just kind of builds, and it's the extent and severity that lupus is affecting the kidneys. I don't know if you guys watch The Voice. I love watching The Voice. One of the contestants was talking about how her sister had lupus and she had kidney failure, and her mom donated a kidney, but it was ultimately unsuccessful. So if any of you watch The Voice, there's your little real world tie-in right there. Okay, acute tubular injury and necrosis. So of course, now we're past the glomeruli, we're into the actual nephron where we're doing the exchange. And so if you get tubular injury and necrosis there, you're talking like major kidney injury. So most common cause of acute kidney injury. It can be ischemic. So if you have a sudden decrease in renal blood flow, so you're thinking hemorrhagic shock, heart failure, anything that's going to lead to lack of perfusion at the level of the nephron, you're going to have death of the tubular cells, and they can slough off into the urine. And that actually produces muddy brown casts because you're getting the tissue. So you're peeing out the tissue. So you see muddy brown casts. That's actually a hallmark of tubular injury. But really, you drop the perfusion there, and that's why you get sudden injury and death of the tubular cells. And then, of course, your GFR drops off significantly. Your tubular cells aren't working, so you're getting oliguria, which again is decreased urine output. So if you have acute tubular injury, you're getting a dramatic drop in urine output. You can also have nephrotoxic, where due to toxic substances. So I just put the examples right here. So ischemic type, it's very patchy. So short lengths of tubules affected, segments of the PST, and then loop of Henle, and then toxic, it's very extensive, which makes sense because you are getting the injury kind of as it's being filtered through, you're getting the injuries throughout the entire length of the nephron. So it makes sense that you would have extensive necrosis across the entire length. So the staging around, so initial, you're going to have a slight decrease in urine output with a rise in blood urea, nitrogen, creatine. So blood urea, nitrogen, of course, nitrogen is just a breakdown product of protein in your blood. You know, back in DM, the whole urea cycle, you have to get rid of urea because it's toxic. And then creatine is muscle breakdown. So these are normal metabolic processes. These are normal catabolic processes that are filtered by the kidney. But as soon as you affect the kidney, these are going to go up. Now, just of note that you'll talk about this in term 5, an isolated rise of BUN can just be dehydration. But if you get a rise in creatine, then you know it's at the level of the kidney. You have a kidney issue. So slight decrease in urine output, rise in BU and creatine, that makes sense because those, if you aren't getting urine output, you aren't excreting those toxic metabolic buildup. And then because you have transient decrease in blood flow, you're going to have a declining GFR. So how are we maintaining this person? We just need sustained decrease in urine output. They will have salt and water overload, which makes sense if you're not peeing everything out, if you're not getting good reabsorption and filtration in the nephron, you're going to have salt and water overload, rising BU, and of course, because you're not filtering it out, hyperkalemia, all of those bad things. Yeah, that just keeps going. So diagnosis, they're going to be hypotensive, low urine output, we talked about that. They're going to be uremic. Serology, of course, we talked about elevated serum creatinine and BUN can get metabolic acidosis. Why? Because the kidneys will excrete hydrogen ions. And so if you're not getting the hydrogen ions out, they're staying in your body. So you have metabolic acidosis. You're also not getting out the potassium phosphate, and then you can have anemia because of decreased erythropoietin. Again, I told you that Money Brown casts are the hallmark of tubular injury. So that's why you're getting that, because you know you have tubular injury, the cells are sloughing off into the lumen, then you're getting it out. Okay, so tubulointerstitial nephritis. So this is just inflammation of the tubular cells. It's not the ischemia. It's not the death of the cells. This is just inflammation. So this is a group of diseases involving inflammation tubules in interstitium. Wow. You'll see azotemia. So this is just buildup of the urea products, as seen as an increased BUN, blood urea nitrogen, because they're not working from drugs or pylo. I spelled that wrong. Okay, so okay, drug-induced nephritis, you're going to see fever, eosinophilia, that's big here. And of course, if you're seeing eosinophilia, you probably have IgG mediated, so hematuria, mild proteinuria, leukocyturia, and then of course, rising serum creatinine, which is indicative of acute kidney injury, of renal cause, or acute kidney injury with oliguria, so decreased urine output. Okay, so I actually put in a slide from our term 5 lecture because I liked how it organized this better than your slide. So I pulled the cystitis stuff from your last lecture into this lecture because I liked how it explained it. So Brady already talked about UTIs, pylo, and everything. So we're gonna go through it one more time. So you can have colonization, bacterial colonization of the periurethral area. You know, it's not a clean area. You know, risk factors are sex and catheters, urinary catheters are one. Females are more prone because of a shorter urethra. So you just get colonization, and then you can get ascension up to the bladder. That's where you get to cystitis, because you're getting that UTI at that point. If it's left untreated, if it's complicated, it can still ascend up to the kidneys, and that's when you get pylo and acute pylo versus chronic pylo. We'll talk about that, but if you keep going up this ladder, you can get to tubulointerstitial nephritis, and then you can get to AKI, acute kidney injury. So I liked how it organized it. It's kind of like a pathway to acute kidney injury versus just kind of putting things in there. So I just put that slide there, and I reorganized it. So acute cystitis, this is just a UTI essentially. So suprapubic plain, dysuria, frequency, urgency. We talked about the risk factors. We talked about the causes when Brady went over the micro, and then labs, UTI, I'm pretty sure all of them are going to have positive leukocyte esterase. And then nitrites, you're going to have the gram-negative organisms. They use E. coli a lot. With that. And then I already talked about how you can get further ascension and get acute pylo, so suppurative inflammation of the kidneys. This is an infection, so the inflammation is suppurative. So you can get suppurative inflammation, suppurative necrosis of the area. You will get neutrophil aggregates. So this is a person coming in onset a severe costovertebral angle tenderness. They'll come in and you can barely even tap on their back. It's like they're in immense pain. And then fever, nausea, vomiting, and fatigue, those are all systemic signs of infection. So you're going to have that as well. And then they might have had a history of UTI. But on this slide, I forgot to point out, you can get hematogenous spread from other places. So if you have like an infective endocarditis, and you get an embolization, it can seed in this area and you can get an acute pyelo. So we already talked about this. This is very, very, very important. You can get a papillary necrosis. Remember, this is a suppurative necrosis. So you can get a papillary necrosis where you have necrotic renal papillae. So this is seen as gross hematuria. Risk factor for this complication is diabetes. And then other ones, you can have pyelonephrosis, which is just buildup. And so since this is an infection, you're going to get an infected buildup, suppurative exudate. You can also get a perinephric abscess if the infection breaks through and goes into breaks through the renal capsule and goes to the perinephric tissue. And you can also get chronic pyelo. I put this in here because I had a couple questions about this because it was put in here that I don't know what this means. So if you're trying to diagnose papillary necrosis, this would be a differential diagnosis. It's not saying it's under the umbrella of papillary necrosis. It's saying that this is something that you could consider if a patient comes in and they have symptoms suggestive of papillary necrosis. So just understand that analgesic nephropathy is a thing, know what it's associated with, and you're good. But chronic pyelo, now you're involving the renal calyces and the renal pelvis. And so this is getting more serious. This is recurrent or persistent infections. So you're having chronic obstructive pyelo, recurrent infections, superimposed infections. But features your gradual onset of renal sufficiency, loss of tubular function. You can develop hypertension, and then you can develop the focal segmental glomerulosclerosis. And then obstructive uropathy, hydronephrosis, essentially anything that can cause an obstruction can lead to this hydronephrosis as fluid build up in the ureter. Which can then lead to renal atrophy, progressive atrophy, because you're getting dilation. So past the obstruction, you're getting the dilation because it's filled with fluid, and so they're getting progressive atrophy because at that point you then have like a non-functional kidney. So it can be unilateral, complete, or partial. It can also have bilateral. If you catch it, renal function can be relieved. And then renal stones. So this is also a very classic presentation. Severe flank pain radiating to the groin. Why is it radiating to the groin? Well, because the nerve fibers are kind of along the same path. Nausea, vomiting. Nausea, vomiting is because of the pain, because the pain can be so bad. Like they say that kidney stones are worse than a woman giving birth. The pain is worse. And so nausea and vomiting simply because of the pain. And then you can have gross hematuria. That's just simple irritation of the area. If you have a large enough stone, you can actually just disrupt the tissue and get gross hematuria. And because you have an obstruction, you have like this foreign thing sitting there, you can get an obstruction, you can get a superimposed UTI due to the stasis of the urine, you can get hydronephrosis. Remember, if you have an obstruction, past that obstruction, you're going to get dilation of the area. And then it can be associated with gout, cystinuria, and hyperoxaluria. Why? Because this you're increasing concentrations of certain things. And so do know the different types of stones and what can precipitate them, because they might ask it. Okay, so remember how we talked about hypertension back in the cardio stuff? It's essentially the same thing here, benign versus malignant hypertension. So you can get nephrosclerosis. So essentially this is just the effects of hypertension at the level of the nephron. So hardening of the renal arteries and small arteries. So benign, you're gonna have the hyaline deposition. So vascular, you're gonna have the medial intimal thickening hyaline arteriosclerosis. You can have global sclerosis at the glomeruli, and then focal segmental glomerulosclerosis. Of course, this is compensatory. And then at the tubular level, you can have atrophy and then ischemia. And then Malignant, remember this is a rapid rise in blood pressure, what makes it malignant, and organ damage. Fibrinoid necrosis of the afferent arteriole, you're going to get that onion skin lesion. Remember, histo is your friend here. And then I put this, the other symptoms in that can clue you in on, oh, this is malignant hypertension. This is what we're seeing right now. And then renal artery stenosis. If you have unilateral renal artery stenosis, this can account for a small number of hypertension cases due to the increase in the RAS system because you have an ischemic kidney. So then you get hypertension. And then, so renal artery stenosis is most common cause is atherosclerosis. Again, that causes a lot of bad stuff. And then another cause you want to make mention of is fibromuscular dysplasia. And then I just included this, arteries in the ischemic kidney are usually protected from the high pressure because, you know, you're going to shift it at that point. So now you're kind of protected from the sharing stress versus the contralateral kidney that doesn't have the sclerosis. You're getting more of the stress because you're taking more of the insults. Thrombotic microangiopathies, they just briefly go through this, but again, just lesions in different systems. This is, and it can have renal failure as one of its characteristics. So again, these are systemic things that just have a renal presentation. One that they love to focus on, and I'm pretty, like, I don't remember which module it is, but one module, they go into every single type of E. coli into great detail. So this is just like a morsel of what you're going to get in the future. But Shiga toxin mediated hemolytic uremic syndrome. Look for a kid that just recovered from a bout of bloody diarrhea. Why did the kid have bloody diarrhea? This E. coli 0157H7. That is what is going to cause the bloody diarrhea. Then they can get this hemolytic uremic syndrome. So a kid comes in, had bloody diarrhea, now has renal symptoms. What was the causative agent? Something like that. You will see schistocytes on the peripheral blood smear, a purpuric rash. The kid can have a headache, confusion, seizure, stroke, fever. And then another one that they throw in there, thrombotic thrombocytopenia, purpura, associated with lupus, HIV, hematologic malignancy. Okay, then cystic diseases, they have a few slides on this. I put in what I remember being like the big stuff. So ADPKD, so this is a, autosomal dominant polycystic kidney disease. This is in adults. So this is associated with the polycystin proteins. It's autosomal dominant, which means all generations are going to have it, unfortunately, and it's going to manifest in adulthood, not in the kids. There are two types, PKD1, if you have the if it's with the PKD1 gene, it's going to be more severe, it's going to present earlier, and then it's going to progress to end-stage renal disease. Something you can also have if you have, if it's the PKD1 gene, or pancreatic and liver cysts. And then PKD2 gene, this is a slower progression, it's more mild, and it's going to present later in life. So what are you going to see? This person is going to come in with hematuria, will have hypertension, flank and back pain. I think when one of the videos I watched, they're like, commonly it's someone gets hit in the back and one of the cysts ruptures and you have gross hematuria. So they're going to come in, they got hit and now they're peeing blood, and then they can find this. Some things that are also associated, you can have a mitral valve prolapse, you can have a Berry aneurysm, and then you can also have clonic diverticuli. And then in the kids, it's autosomal recessive for the fibrocystin proteins, and then it's the PKHD1 gene. Alport syndrome, can't see, can't pee, can't hear or be, straight from first aid, but they're going to come in with it's a mutation in the type 4 collagen. So you're getting irregular thinning, thickening, splitting of glomerular basement membrane, which causes a basket weave appearance on electron microscope. And then the gene is the COL4A4. So the patient's going to come in with hematuria. They're going to have sensorineural deafness. Yeah, so look for those two things. So renal, eye, ear. That's outport syndrome. And then I'm going to quickly go through these. There are a couple things that they like to associate with the renal tumors, and I'm just going to tell you what those are. This is just the introduction. So an angiomyolipoma, that's benign. It's like a fat tumor. Renal cell carcinoma. This is malignant. The biggest risk factor is smoking, also obesity, hypertension. Highlight polygonal clear cells. If they talk about polygonal clear cells, you can assume that you are talking about renal cell carcinoma. Also highlight star, it can invade the IVC. So you get hematogenous spread to the lungs and bone. That's very big. So it can invade the renal vein, and if it grows within the renal vein, it can extend up to the IVC. And this is how you're getting the hematogenous spread of this cancer. Highlight that. So what is the patient going to have? Hematuria, you can have palpable mass, flank pain, fever, weight loss. You know, all of those are pretty non-specific. Hematuria, you know, is kind of kidney. And so palpable masses might be able to clue you in, but the clinical the symptoms aren't necessarily what's going to clue you in. What's going to more clue you in on is the histo, you know, the polygonal clear cells, if they put this slide on there. Another thing that I don't know if they've introduced it to you before this point, paraneoplastic syndromes. So oftentimes it's hard to diagnose something because the actual cause is mimicking something else. So for example, this is so big in respiratory. So when you get to the lung cancers, oh my goodness, there are so many paraneoplastic syndromes, like it's crazy. But essentially you're presenting as one thing and it's kind of masking what it actually is. So even though it's something wrong with your kidney, it's acting like it's a different thing. So abnormal hormone production. So it uses Cushing syndrome as an example. So all of these different things, they have nothing really to do with this, the renal cell carcinoma, but the paraneoplastic syndrome, it's kind of acting like it's something else. So you could be worked up for something that has nothing to do with what it's the actual causes. So that's paraneoplastic syndrome. I'm pretty sure this is one of the first times they introduce it to you, but it becomes really big later. Wilms tumor, this is in kids, WT1 gene on chromosome 11p, large, well-circumscribed mass. Anaplasia correlates with presence of TP53, and then prognostic factors, anaplasia. I'm pretty sure you guys talked a lot about that in FDCM. Anaplasia is pretty much loss of differentiation, which is very bad when you're talking about cancers. So make that association. And then congenital anomalies, I put this on here because I don't remember this being a huge thing. I remember references of vesicouretic reflex in other places, but not on its own. And then bladder tumors, the biggest thing are the risk of smoking, and then this cystomiasis or whatever. So cystosoma, I don't know how to say that, but those are the two biggest risk factors for bladder cancer, associated with squamous cell carcinoma. But that is it, guys.
All right. So we're done. Good luck. If y'all have any issues, y'all could just message us. Y'all thank Lindsey for this when she put all the work in and did the slides. She convinced me to do this. So like I said, our exam is Tuesday, but if y'all need anything between now and then, we'll do our best to get back to y'all.
Yeah.
So good luck.
We'll be sending you well wishes. That's how we're helping at this point.
Sure. All right, bye guys.